Good morning, everyone, and thank you for joining us on what is the third of our Maternity Matters webinar series, this time focused on perineal injury and the devastating, life-changing impact it can have on women after giving birth, whether physically, psychologically, and economically. So my name is Anne Kavanagh. I'm a partner in the London Clinical Negligence team, and I'm joined today by colleagues Sarah Whelans from Cambridge, Sharon Williams from Manchester, who will chair the first and second sections of the webinar. Rochelle Mahapatra is a partner in our Leeds office, and she'll present alongside her client Ashley Roper. Shivi Nathan, a partner in our London office, will present alongside her former client, Sarah Davison. And finally, Julianne Moore, who's a partner in the Sheffield team, will chair the Q&A sessions. So we cannot pretend to cover this complex area of maternity care in one morning, but we hope to offer you some insights into patient or client experiences, and that of our expert speakers can offer practical guidance and tips on prevention, identification and treatment of these injuries. We have a wonderful programme of speakers ahead, and full details are available to you in the webinar programme, which should have been emailed to you earlier this morning. I would particularly like to thank our clients, Sarah and Ashley, for offering to share their very personal experiences with us this morning. So the programme ahead reflects the fact that due to clinical commitments, some of our experts are only able to join us for a short time, and we've therefore built in short Q&A sessions with them, but there will be a longer panel Q&A at the very end of the webinar from around 12:30 onwards. Some small housekeeping points. The recording of the webinar will be sent to you by email soon after the live event has taken place, and you'll be able to watch it again or share with colleagues. Many of you have already submitted questions for the speakers, and you can submit questions throughout the webinar using the Q&A function on your screen, and these will be addressed in the final panel discussion. When submitting questions, please do include your name and email address so that if we don't get to your question today or during the live session, we can email you a response directly afterwards. And finally, towards the end of the session, we'll post a feedback link, and I would encourage you to take a couple of minutes to complete that if you can. So I'd like to hand over now to Sarah Whelans from our Cambridge team, who will chair the first session. Thank you. Sarah, over to you.
Thank you, Anne, and thank you everyone for joining us today. Starting our discussion today, we hear from Ashley and Rochelle. Ashley is a client of Rochelle Mahapatra, partner in our Leeds office. Ashley is kindly joining us today to share her story, and Rochelle will support Ashley in explaining the legal journey in some further detail. Over to you, Ashley and Rochelle.
Oh, hello everybody, and thank you very much for that, Sarah. I just wanted to say about Ashley how incredible it is that she's actually sharing this story. We all know how difficult it is to talk about these issues, and in these cases it is critical when an injury has occurred that it's identified quickly and it's also repaired quickly. Unfortunately, in Ashley's case, that didn't happen. It was identified, but it was inappropriately repaired. And as a result, and she will explain to you the impact of that and how many subsequent surgeries she had. She's an incredible speaker. She speaks passionately about the impact on her and her family, her relationship with her son, and I would just like to now hand over to you, Ashley. Thank you very much.
Hi everybody, so my name's Ashley. I live in West Yorkshire with my little boy. Obviously, as Rochelle said, I had a lot of problems. When I had my little boy, I was diagnosed with a 4th degree tear. Went straight into surgery and had 3 hours surgery where obviously I didn't see my son. Came out of surgery thinking everything was fine. Within a week of being at home with my little boy, I noticed feces and flatus coming out of my vaginal area, which obviously had a massive impact on my relationship with my son as well. Went back to the hospital who proceeded to tell me that that was normal. And for 6 months after having my little boy, was told, yeah, you'll heal, it'll be fine, it'll be fine. After 6 months, I saw a colorectal expert, and he proceeded to tell me that I had a fistula, which was then repaired a few weeks later, within a week that had failed. I had then to be told I had to have a colostomy bag fitted. Within 4 weeks, I had a colostomy bag. I had to wait another few months, had another repair that failed within 4 days. I had another repair in the Christmas after, that also failed. And then I was referred to an expert in Leeds who did me a Marsh's flap repair and also converted my loop colostomy to an end colostomy. So I was then left with an end colostomy and a lot of healing to do after that. Proceeded to tell me that my sphincter muscles had gone in the process, so I had to have them repaired. Eventually, another 8 months later, I got rid of my colostomy bag, which has now been gone for 18 months, thankfully. So I am now on the straight and narrow. I have got massive impacts it's had on my life. So obviously it's affected my relationship with my baby's father. We are no longer together. There was a lot of arguments, a lot of tension, stress. Physically, it ruined the relationship physically. So obviously we called it a day there. We are very civil with each other, luckily. The relationship with my son is fantastic now. It's absolutely amazing now. But to start off with, in a way, I did blame him because he had given birth to him, and he'd done this to me as such. Obviously, the long term, it wasn't him. It was effects that surgery had had. But obviously, I've built on that relationship. The biggest thing for me is that I never got to dress my son for the first time. I never got to feed my son for the first time. I never got to cuddle him until 3 hours after he'd been born. Still to this day, it tears me up thinking about that. I have a fantastic family who have been an amazing support to me. My mum is a nurse, has been since she was 17, so she knows a lot about the impact it's had on me. She's been there when I needed her. She's been there all the time for me and my ex-partner as well, which has been amazing. My sister has been there to look after Albie every time I've gone into hospital. So I've had 6 operations. She's been there every time. My grandma, who's 84 now, has trekked back and forth to the hospital every time, every day to see me. Psychologically, I have never really been right with my mental health since I was younger anyway, but this has had a massive draining impact on my mental health. There are times, I will admit, in the last 4 years where I've thought, is this worth it? Is any of this worth it? And should I just give up now? Obviously, family, sorry, getting all tearful. Obviously, family-wise, they've been there, they've come, they've stayed, they've taken my little boy away, so I've had some time to myself. You know, my ex-partner booked me into a spa so that I could just have some time just to relax and get there. And obviously now I am at such a better place in my life than I was over the last 4 years. Obviously Rochelle knows in detail more about what's happened mentally and things like that. I've had to have assessments, I've been put on medication. I am off the medication now, so that's a really positive thing for me, and I am moving forward with my life. Looking to the future, I have still got some ongoing issues. So I have some fecal incontinence, I get staining, which has been reported. I also have urinary incontinence, which I am under another specialist for now, who I'm actually seeing tomorrow. I've had a lot of tests done to do with that, and they're now deciding whether that is in relation to the operations that I've had. But yeah, I'm glad there's an end to what I've been through, and the biggest thing for me is I want an apology for the fact that people have done things wrong and haven't taken that duty of care in looking after me like I would my son, who I couldn't. So yeah, that's my story. That's the biggest thing for me, is that it's at an end now, and hopefully the future is a lot brighter.
Thanks very much, Ashley. I mean, it's very powerful stuff, and I think actually it shows the importance of good communication as well throughout the period, which is another thing that you feel that you were let down with. And hopefully things will continue to improve for you. Thank you very much for sharing that.
Thank you.
Thank you, Ashley, for such a candid account on a topic which is sadly not discussed enough. I certainly had tears listening to Ashley's brave story. Thank you, Rochelle, as well, for supporting Ashley with that. Just a reminder that we have 2 Q&A sessions with our fantastic panel of speakers, so please do drop any questions you have into the chat function to pick up at one of those sessions. I now introduce our next speaker, Andrew Farkas, who is a consultant obstetrician and gynaecologist. Andrew works at Sheffield Teaching Hospital and has done since 1996. Previously, he trained and was a senior lecturer in London. He has a special interest in all aspects of urogynecology and in particular vaginal surgery. He maintains the linkage between obstetrics and gynecological practice, managing 600 patients each year, as well as being the lead clinician to the placenta adhesive spectrum, PAS, and abnormally invasive placenta AIP service. Mr. Farkas is an experienced medico-legal practitioner preparing reports on the instruction of both claimant and defendant solicitors. For many years, he was a member of the Directorate Risk Management team addressing issues on perineal trauma and other birth injuries. So a very suitable speaker for today's topic. Over to you, Andrew.
That's very clear. A lot of what I'm going to say, and particularly our case study, is not dissimilar to Ashley's story, but it does bear repetition. If we go on to the next slide, what I want to talk about particularly is obstetric anal sphincter injuries, but I don't think we should forget that there are a whole host of other perineal trauma problems. Episiotomy problems, episiotomy breakdown, scarring, pain, vaginal scarring, vaginal narrowing, dyspareunia, all sorts of issues, both in the short and the longer term, that can follow childbirth. I'm going to not talk particularly about those in the talk, but very happy to address those, and Sue Bryden may well talk about some of them in her talk. If you go on to the next slide, please. I mean, this is essentially what I'm going to talk about mainly. There is a picture of a 3rd degree tear, and it's a 3B tear because it's showing complete disruption of the external anal sphincter, which are the ones grasped by the forceps. And I think that's the sort of tear that we most commonly see. I mean, as you know, incidence varies on what people think is the incidence of 3rd and 4th degree tears. And it's very difficult to know whether the incidence has been increasing over the years, or whether it is because there is more awareness and better detection, or a bit of both. But it's certainly, the figures in the literature certainly suggest an increased incidence. I suspect there's quite a lot of that is increased awareness. If you go on to the next slide, please. I mean, here are a number of quotes, and we've heard similar things already this morning about the problems of fecal incontinence, how it impacts on social life, working life, sexual function, and care of the newborn. And let's not forget about the newborn. It is difficult to care for a newborn at the best of times, and particularly if you're chasing to the toilet or not getting to the toilet all the time. And there are a few more quotes on the next slide. And it happens very suddenly. I mean, childbirth is a fairly sudden event by and large, and the change from being a pregnant woman to a postpartum woman with a young baby, and all the issues around that, both physical and psychological, and add to that a major problem like incontinence, it can be devastating, and it puts a burden on the woman, her family, family relationships, and so on. Going on to the next slide, you can see the Royal College guidelines, and we live in an era where an awful lot of what is done is dominated by guidelines. You can call it death by guidelines, call it what you will. And some of these guidelines are well written and some are less well written. I mean, I think this is actually a good one in that it is relatively concise, about 15 pages, and it is relevant to what the likes of myself and my trainees do in day-to-day clinical practice. It's not a sort of mega overview of the literature. It's relevant and appropriate. And it also touches base with reality. I mean, a more recent guideline that I haven't put a slide up on about, which we can talk about in questions if you like, is the OAC Care Bundle, which from 2018, which is a refinement of, or a distillation of elements of the original RCOG guideline. But that, I think if you're going to read one thing, that 15-page guideline is probably the most useful thing. Let's go on, if we can. I think a lot of obstetric anal sphincter injuries can be not necessarily predicted, but there are known risk factors, and one can have a good idea of who might be more at risk than others. And there's nothing particularly novel about a lot of these. Are all in the guidelines: nulliparity, big babies, shoulder dystocia, OP positions, prolonged second stage of labor, possibly epidurals, Asian ethnicity. They're well-known risk factors, and I think it just behoves people that when examining a woman postnatally, if these risk factors pertain, to be particularly careful. I think one of the major risk factors, as shown on the next slide, is operative vaginal delivery, and here you can see odd ratios with confidence intervals, and overwhelmingly the most predictive for obstetric anal sphincter injury is a forceps without episiotomy. I don't want to get into sort of battlegrounds about episiotomy or not episiotomies, but I would be fairly clear that when doing a forceps, you should do an episiotomy. It's more arguable about ventosas, but if you're putting in on a pair of forceps, you're increasing the diameter that's presenting to the birth canal, and I think it is sensible to do an episiotomy, and we'll come to episiotomies in a moment. I've mentioned some of the risk factors, but another thing that's often not mentioned is how you can anticipate and just have a sort of eye for what's going on. And on the next slide, I just mentioned a couple of things. And that's very basic. Looking at the progress in the first stage of labour, looking at the progress in the second stage of labour. And both will give you an indication of potential trouble. And I appreciate that both of these are often associated with many of the other variables that we've discussed above, like big babies, primiparity, regional anaesthesia, the works. But I mean, partogram is a single graphical piece of evidence and often gives a clue to what's going on. The risk of OASIS is given at between about 2 and 8%. What's the risk in a future pregnancy? Well, if you look at the next slide, it's probably around 5 to 7%. And women should be warned about that when discussing mode of delivery in a subsequent pregnancy. There are lots of issues around consent, which I will try to avoid getting bogged down to arising out of the care bundle. But I think this is one piece that one can't escape, that there is an increased risk in a future pregnancy. And there's also a risk of worsening fecal incontinence, particularly if there are persistent symptoms. So how do we prevent oasis? I suppose one slightly trite response would be to do cesarean sections for everyone, and I think that would be the wrong response, because that brings on a whole host of problems of themselves. But there are things we can do, as shown with the next slide. And as in lots of aspects of medicine, lots of aspects of obstetrics and gynecology, the pendulum swings backwards and forwards. And episiotomy with operative delivery we've mentioned. I'll show you a slide in a moment of the episiotomy scissors, the EPIS scissors. A lot of people use them, a lot of people don't use them. There's no right or wrong. I'm very glad as an obstetrician, and some of the midwives in the audience may disagree with me, but I am very glad that perineal protection has come back in vogue. I think that is terribly important. Hands on the head, keeping the head flexed for as long as possible, and perineal protection. What one is trying to do anatomically is allow the smallest presenting diameter cut to come through the birth canal, and it seems only sensible that doing so with perineal protection and stretching the perineum will minimize, it won't abolish, but it'll reduce the risk of trauma. And that, I'm pleased to say, has come back into vogue. Warm compresses in the second stage of labour, the Cochrane review found evidence for that. The next thing, I mean, inevitably, even with good care, or the best care, obstetric anal sphincter injuries will occur. How do we identify? Well, that's shown on the next slide. Those are the episiotomy scissors at 60 degrees on a model, on a perineal trainer. And if we go on to the next one, please. Suspicion of injury. And the points made below highlight the reason for repairing these injuries in theatre. A good light, adequate analgesia, positioning the patient, good assistance. All of those make it easier. If you don't identify an injury, and if you don't identify the extent of the injury, how can you be expected to repair it properly? You can't. So stage one is identification of the injury. And that's absolutely crucial. And usually it's the midwife or the doctor doing an operative vaginal delivery who has a suspicion of it. But, you know, further clarification of the nature and the extent of the injury is obtained on examination under anaesthesia. Going on, part of that identification is rectal examination. It used to be the case that doctors were expected to do rectal examination and midwives weren't. I think it is sensible that the practice has shifted such that everyone is expected to do a rectal examination to identify whether the anal sphincter is intact or not. And there's a pill rolling of the thumb and the forefinger to see if there is tissue between the two, sphincter tissue between the two. Again, pendulums swing, and 15, 20 years ago, there was interest in so-called occult injuries. My understanding is that the occult is associated with witchcraft more than with medicine, and I'm glad that the term seems to be fading. I don't think there are occult injuries. I think there are missed injuries, sometimes understandably, if there's only a partial injury of the sphincter. Sometimes there is huge disruption of the sphincter that shouldn't be missed. So I think occult, the term occult, was dressing it up. Endoanal ultrasound scan by Abdul Sultan and Rani Thacker was a research tool, and fair enough, but I don't think it has gained acceptance in the clinical setting. So on the next slide, what constitutes a missed obstetric anal sphincter injury? Well, you can have a missed third-degree tear involving disruption of the external sphincter, internal sphincter. You can have a mixed fourth degree, and you've got to be a little careful here because a fourth-degree tear is a tear involving disruption of the anorectal mucosa, and a lot of tears extend to the anal verge, but it depends whether the tear goes into the anorectal canal. And then a buttonhole injury is not, strictly speaking, classified as a third or fourth degree tear. And going on to the next couple of slides, we've just talked about that. And you've got to be careful with an external sphincter because it's a three-dimensional structure. It's got length and it's got thickness. And a question that is raised medico-legally in cases of missed injuries is, should that tear have been missed? And in the acute situation, I think complete disruption of the external sphincter, particularly if involving the internal sphincter, shouldn't be missed. Fourth degree tear obviously shouldn't be missed, but it's very difficult to say, it would be my view, and others may disagree, that a partial tear, a partial disruption of the external anal sphincter, that one can't legitimately miss that because one might not identify all of the upper fibers and one might miss the fact that there has been some disruption of the external fibers. Buttonhole tears, I think with a competent digital rectal examination, should be identified by and large. Now, on the next slide, you'll see a picture that many of you will be familiar with. Endoanal ultrasonography with disruption, a big disruption there of the external anal sphincter. And that's been around now for 25 to 30 years and has completely revolutionized the thinking about obstetric anal sphincter injuries and how we manage these, particularly postnatally. And it's a tool that is open particularly to the colorectal surgeons, but to an extent to the obstetricians and gynecologists. And I'll come on in the due course to the difference between structure and function. And so one has got to be careful about the interpretation, but it gives you a very accurate view of the anal sphincter complex in addition to clinical examination. So let's move on to treatment with the next slide, please. I've talked about anticipation, risk factors, recognition, appropriate intraoperative and post-operative care, and doing such repairs in the theatre. Documentation, as the lawyers amongst you in particular will recognise, is crucial. You need to document the extent of the injury and the nature of the repair. We have most units now use pro formas for their perineal trauma, whether it's third degree or just straightforward perineal trauma. Yes, they have a lot of benefits, but there is a temptation to tick boxes and miss out to an extent on detail and certainly diagrams, and that is also a problem with electronic patient records of inserting diagrams that can often be very valuable. Debriefing the patient, follow-up, and then a risk management strategy. So on the next slide, who should perform the repair? Apologies. The repair itself involves a rectovaginal examination that we've discussed, repairing in the theatre. Regional anaesthesia gives you a whole world of access that you don't get with local anaesthetic. I mean, very occasionally these repairs have to be performed on delivery suite because of postpartum hemorrhage or some other reason. Fair enough, but in which case you may have regional anaesthesia, you may not, but in which case it should be documented why it's being performed on labour ward, not in theatres. Antibiotics regimens differ from unit to unit, but certainly some per-operative antibiotic prophylaxis and different units advise differently for how long you carry it on, whether intravenously or orally. Wound care, laxatives, that you don't want the patient to be too loose, that's not good, and you don't want the patient to be constipated or straining. Bladder problems are often associated, particularly with a regional anaesthetic and a sore perineum, and then appropriate follow-up. So, moving on to who should perform the repair. I mean, it is almost invariably done by an obstetrician and gynecologist, not by a colorectal surgeon. I mean, vanishingly rare for a colorectal surgeon to be involved in the acute situation, unless it is a particularly bad 4th degree tear. I think a positive disadvantage is that the colorectal surgeons don't see the acute injury. They see the secondary repairs often, but not the acute injuries regularly. And they may subject to a woman to a stoma, which one could question the benefit of. How do you judge adequate skill and seniority? That's difficult. I mean, most trainees now go to a perineal trauma course that gives, that's a day. It familiarizes people with the concepts, it familiarizes them with repairs on models and animal tissue models, often porcine, and that's very helpful. I'm not sure that a day of doing it just by ticking the box makes you adequately skilled. And a defense is often, oh, so-and-so attended a course. Fine, well, does it make it him or her skilled? Not necessarily. And it's very difficult to identify who is sufficiently skilled, who is sufficiently senior. For example, should a consultant be involved in all 4th degree tears? I think unless exceptional circumstances pertain, probably in this day and age, yes. 10 years ago, possibly not. But then you've got the borderline of someone who's about to be appointed a consultant. Do they need to have another consultant with them? Certainly, I think they should discuss the case with them at the very least. Going on to suture material. Most repairs of perineum or the anal sphincters are done, certainly the perineal, standard perineal repairs are done with polyglactin, Vicryl, Maxon similar sutures, and Vicryl sutures to the vagina. Most repairs to the anal rectal mucosa are done with Vicryl or similar. What do you repair the anal sphincter with? Most obstetricians, and I would imagine most colorectal surgeons in the elective situation, use PDS, which is a much more slowly absorbing suture material. It takes about 3 months to absorb. I mean, the problem can be that they leave sort of knobbly suture ends that are uncomfortable, and they can be cause discomfort, but they probably allow a more prolonged period of healing. I've been fired a question on our chat conversation button. Why would you ask a colorectal surgeon to perform the difficult repairs, given that they never do the easy ones? That's a very fair question. And I would suggest that if you have a nagging doubt that it is such an awful tear that a stoma may be required, then it's sensible to involve the colorectal surgeon from the outset. Secondly, if you've got a difficult case, sharing a difficult case with a colleague is often a good idea, and that colleague can either be another obstetrician gynecologist or it could be a colorectal surgeon. And I mean, I don't want to denigrate my colorectal colleagues. I mean, they do deal with damaged anal rectal mucosas, they do deal with sphincters, more usually in the elective situation, and they do have a role, but it's a relatively limited role, if I may suggest, in the acute situation. Now, going on to the technique. The internal anal sphincter is repaired by an end-to-end technique, and a full thickness, well, partial thickness and an external anal sphincter is usually repaired with an end-to-end technique. It is said that you can't get any overlap with a partial thickness. I'm not quite sure I accept that, but that is the received wisdom. And then with a full thickness and external sphincter, you can either use an overlapping or an end-to-end technique. And on the next slide, there are a couple of diagrams showing the two. And the top one is an end-to-end repair, and then you're trying to get an overlap on the bottom. The colorectal surgeons will by and large, use an overlapping technique in their secondary repairs. And I can't help thinking that you get a better muscle bulk, but the evidence base for overlap versus end-to-end is limited. So my preference is an overlap repair in the acute situation of a full thickness external sphincter disruption, but it's not, the evidence base is limited on that. So let's move on to a case study, and this is documentation before we move on to case study. And I mentioned some of this before. Extent of the injury, the layers repaired, and they can be vaginal, external sphincter, internal sphincter, anorectal mucosa, perineal body, skin, the suture material, follow-up, and we've discussed issues around proformas. And then going on to the case study, and we've heard quite a lot of issues raised in the case study before, but let's go through it fairly briefly. If we go on to the next one, please. Yeah. And I mean, this case study illustrates, and it is by and large based on a single patient, anything and everything that could go wrong. A woman having an instrumental delivery for thick meconium and suspicious CTG. The baby was delivered, but the woman sustained a large 4th degree tear. And I would note that it is a large 4th degree tear. Now, on the next slide, poor documentation, no detailed description, discharged from hospital. My view is that a woman should stay in hospital till her bowels are open after a 4th degree tear, though not necessarily after a 3rd degree tear. Stitch material came away, lack of review, and furthermore, as you'll see on the next slide, she was never really properly informed about what was going on, what advice she should do, postnatal appointments. I'm a little more sympathetic about the postnatal appointment because a lot of patients get their appointments by the post, so I don't think one should necessarily damn them for that. Eventually at home, she was told by the community midwife that she'd suffered a 4th degree tear. And then you can see where the story is going on the next slide. Passes feces vaginally on day 6. The midwife appropriately makes an immediate referral to hospital, obstetric and colorectal input, and she has an examination under anesthesia, and a large defect in the rectum with pus coming in, a lot of suture material. So, I mean, this represents an early breakdown, and the inference from early breakdown tends to be one of two things. Either it wasn't repaired properly, or or it wasn't identified properly even before that. Sorry. And she underwent a colostomy, became septic, and then to add insult to injury, a swab was left in place, needed a laparotomy, a colostomy, eventually did okay. But, you know, a pretty disastrous case. So, and if we go on to the next slide, you will see the outcome. it went to litigation, and not surprisingly, the case settled. I mean, I think that was almost inevitable with that case. I mean, that's indefensible at every level. So post-operative management, and these letters after the bullet points are the evidence based from the guidelines, from the RCOG guidelines. Broad spectrum antibiotics, laxatives, but be wary about giving bulking agents, i.e. fibergel, as well as laxatives, physiotherapy, and we're going to hear about postnatal physiotherapy, and the perineal trauma clinic. Perineal trauma clinics, most patients are seen, some are run by obstetricians, some by a midwife or a nurse with an obstetrician, and it is only a selection of the more severe cases that gets seen by a colorectal surgeon. I would suggest it's not practical for, in many instances, not practical to have a joint perineal trauma clinic with an obstetrician and colorectal surgeon. It's a very high usage of consultant time. I mean, it is done in some cases, but not in all. And I'm not critical if their patients are selected and then sent to the colorectal surgeon subsequently. So moving on to why repairs fail. Incorrect identification. As I said earlier, if you can't identify, you can't repair. Poor technique, hematoma, fecal impaction. Infection is often cited as a cause of breakdown, and yes, perineal trauma can break down, but I am cautious about, and I think a lot of medical legal experts are cautious about whether infection will actually cause breakdown of an adequately performed sphincter repair, and I realize that that's an issue that is debated. How do we plan for the future? If we go on, there's a limited evidence base, but I think patients with ongoing symptoms or a significant structural abnormality at the anal sphincter are usually advised to deliver by elective caesarean section, and then we've got to take into account the patient's wishes. The counter argument is that most of the damage has been done. Will you get further damage from a further vaginal delivery? And it's not a clear cut. There isn't a clear cut answer to that. We're nearly finished. So get a couple more slides. If we go on to the next one, don't forget about other perineal trauma, often associated with postpartum hemorrhage that makes it both difficult to identify and to treat. Issues around dyspareunia, body image and relationship issues. Perineal revision or Fenton's procedure is a commonly undertaken procedure. The need for it is usually non-negligent and very difficult to prove negligence in those cases. And so finally, can we improve the situation? Training courses, it's very difficult to evaluate the impact, but I think one thing the training courses have done is to heighten awareness. Recognition is crucial, good technique. And one of the things I've learned on the training courses, it's not so much the specifics of suturing a sphincter, it's the overall technique of handling tissues, handling instruments that one can learn or teach certainly on these courses and documentations. Thank you very much. I will leave it at that stage.
Thank you, Andrew. That was really interesting, if not a little bit scary. But you'll be pleased to hear that we have received delegate feedback from a midwife supporting perineal protection. Thank you for your questions you've already submitted, and just a reminder to post any questions for our speakers in the chat function for our speakers to address in one of our Q&A sessions. So I now move on to Paula Ignalada Martinez, a clinical lead physiotherapist. Paula initially trained as a physiotherapist in Spain and qualified in 2000 with a degree in physiotherapy from Manchester University. In 2011, she completed her Masters in Women's Health Physiotherapy at Oxford Brookes University. Since graduation, she's worked in various NHS hospitals, including Adam Brooks, Bart's and Guy's and St Thomas's, as well as some private physiotherapy services. Since 2007, she has been the lead for the women's and men's health physiotherapy service at Guy's and St Thomas's. This has allowed her to work with urology, urogynecology and colorectal teams, giving her a great insight into the advanced assessment and management of pelvic floor related disorders. Her main interest is the effect of physiotherapy on pelvic floor dysfunction following childbirth. Over to you, Paula.
Okay. Good morning, everyone, and thank you very much for a lovely introduction, and thank you for inviting me to speak about physiotherapy in the perinatal period. I was thinking about, when I was preparing this presentation, what will be a good, sort of snapshot of what we do. And so my aim today is just to give you an overview of what we do during pregnancy, in the acute postpartum period and in the postnatal period. By all means, at any point you have a question, to ask me at the end in the question and answer session. Next slide, please. So as you might have heard, I'm sorry I missed the initial presentation from you, Dr. Farkas, but the pelvic floor is actually made of three distinctive layers: the endopelvic fascia, which I normally call the clean film, the one that makes sure that everything is together and attached to the pelvic walls, the elevator ani, which is the deep pelvic floor, and the superficial pelvic floor. And the aim of that pelvic floor, of course, and the endopelvic fascia, is to support the pelvic organs, make sure that we don't have incontinence, and obviously there is a small role there as well in terms of sexual function. Next slide, please. So how does pregnancy and childbirth affect the pelvic floor? Obviously, during pregnancy, the muscles and the fascia are under the effect of the hormonal release, so estrogen, progesterone, relaxing, whereas they're good because they allow us to have vaginal birth. It's also affects the connective tissues, so the endopelvic fascia and the pelvic floor muscles, and so the muscles are actually already carrying extra weight. And not only that, during childbirth, the pelvic floor muscles are stretched up to 3 times the original size. So it's actually quite a lot. For me, it's a miracle when I see those women, after childbirth, But then obviously having an instrumental delivery will actually affect both the fascia and the pelvic floor. And then the difference, for example, in terms of nerve injury or neurological injury, there is a mismatch into how much the pelvic floor muscles kind of stretch versus the pudendal nerve. And the pudendal nerve is the one that actually controls the pelvic floor and some of the bladder and bowel empty mechanism. And just to give you an idea, that whereas the skeletal muscle, so your pelvic floor can actually stretch up to 200% of the regional length, so it's there ready to do that job. Nerve tissue does not actually stretch, it only allows that 15%. So, think about those very difficult second stages and the use of episiotomies and, forceps, all of that will have an impact. Next slide, please. And this is a bit of a in your face type of images, obviously all of that leads to oasis, of course, second degree tears, pudendal neuropathies, which means that you don't have the sensation. We also know that avulsion, that's when some of the muscle fibers become disattached from the symphysis pubis. Joint, obviously there is a range of weakness. You can actually see on the right lower part of the picture, there's an MRI of the pelvic floor. The orange one, if you can see, is someone before children, and the blue one is someone with a prolapse, for example, whereas the green one is someone who's got an avulsion, so these are real women, and the yellow one is just someone with childbirth. You already know that there is a difference between having babies and not having babies, right? So all of that leads to what we know is called pelvic floor dysfunction. Next slide, please. And pelvic floor dysfunction, just to give you the statistics relevant to this group, so that to postnatal women, we know that 1 in 3 women will have a stress urinary incontinence, 1 in 10 women will have anal incontinence, 1 in 12 pelvic organ prolapse, and sexual dysfunction, dyspareunia is actually experienced, during that first year. I mean, sexual dysfunction as well is a bit more difficult to sometimes to evaluate, because when you just had a baby and you're breastfeeding, you're fatigued, there is quite a few other things going on emotionally that might have an impact on your overall experience of sex, compared to sort of, yes, you have that weakness because you have a forceps delivery and now you have incontinence. I don't know if that makes sense to you, but yeah, so, and then sometimes they might actually have a combination of all of this. Next slide, please. So, I'm talking about this is a specific group of women, and, our input in the perinatal period goes from the 12 weeks of pregnancy up to a year postpartum. And we're lucky at St. Thomas's because we have kept our obstetric service, which means that we also see the women on the postnatal ward, all right? But our implications most of the times at national level is that during the antenatal period, we'll actually see them for musculoskeletal related disorders and antenatal education. In the acute postnatal period, we will triage, and most people will see the 3rd and 4th degree tears, forceps deliveries, and then the postnatal period, it depends for everyone. We see women from 6 weeks up to a year, but obviously our care doesn't stop there. We see women, one of my patients at the moment is 92, yes, and she's got incontinence while doing yoga. So, when it comes to postnatal, we define that as to 1 year postpartum, but our care obviously is ongoing. Next slide, please. And I was saying to Alice yesterday, I love Mary Poppins, so any opportunity for me to bring on Mary Poppins on any presentation, I'll do it, yes. But, what are the trade of our tools? Obviously, when we think about physiotherapy in general, we have exercise, we have gadgets, everyone thinks about some things that we're going to do to women, perineal massage, certification techniques, but let me just go a little bit more in detail. So next slide. So I'm a true believer in prevention is better than cure, and I think we now have the evidence to know that informing women about pelvic floor muscle training, it's actually it does actually improve, urinary incontinence in the postnatal period. And the latest research shows that actually group-based pelvic floor muscle training is actually an effective intervention. From my point of view, for example, how we have changed, our classes here at St. Thomas's is that we have a specific pelvic floor class where we actually also talk about pelvic floor dysfunction, because I think pelvic floor dysfunction is not something that women are aware. And then when we see them in the postnatal period, one of the main things that we hear is, no one told me about this, no one told me that this might happen. And I think that comes with a lot of frustration and negative image, what Dr. Farkas was talking about, the whole, how you feel as a woman, it's actually completely shattered because you didn't know. So being aware, and on the antenatal group, I'll go, okay, so how many of you do you think you have problems with the bladder? And most women are first-time mothers, because that's when you prepare the most, isn't it? Once you have second or three children, you just don't have anything. So of those first-time mothers, when they hear about urinary incontinence, the face, opens up, and I go 1 in 3, and I go 1, 2, 3. 1, 2, 3, just to give them sort of an idea of how often it happens, because I think for most women, that's just not something that you hear until you actually become pregnant or have a baby. So next slide. At St. Thomas's, both us and the midwives are obsessed, obviously, about informing women about perineal massage. And what we know now is that in those first-time mothers, perineal massage is enough to sort of lessen the risk of perineal trauma and also dyspareunia in the postpartum period. And if you do tear, because sometimes we have women that say, but Paula, I did my perineal massage, why did I tear? Well, it's something that, the size of your baby, the length of your perineum, how you push, there is so many variables, but what we know is that you actually do perineal massage, there is less risk of you tearing, and if you do tear, the risk of, the degree of tear is decreased. So it's actually good. And obviously on our classes, we also go, and discuss the best birthing positions. And what we know as well is that combo of perineal massage and pelvic floor muscle training during pregnancy is actually the best outcome in terms of decreasing the risk of tearing and decreasing the risk of pelvic floor dysfunction. Next slide, please. Obviously, we work very closely with our consultant, and I'm actually part of our interprofessional Oasis clinic. So we are also obsessed about Oasis in our unit. So we tend to sort of, obviously, we are part of the Oasis care bundle, and we had the Peaches, which was actually protection of the perineum, and that in itself was enough to reduce the Oasis incidence in our trust, but we now, in line with the Perinatal Pelvic Health Service Implementation Project, we have actually going to start doing a pelvic floor assessment. We have a risk assessment tool for all pregnant women, so we can actually already identify women that are at risk of developing early on in pregnancy and have those conversations. And I think, again, informing is the way forward when it comes to women. And I think empower women to discuss with their obstetrician, the midwives, of course, about their choice of delivery. And I think obviously your choice scoring system is a debatable one, right, for many reasons, but actually your choice score, if you haven't heard about it, is actually like a risk tool, that sort of gives a woman a risk of how likely are they going to develop pelvic floor dysfunction. So it measures like your height, how old are you, sort of things, and that will give you a risk of, prolapse and urinary incontinence. So although it's good, it's once you have actually the risk tool is for women up to 35, so that's in itself a big thing, whereas nowadays, more women actually having babies later, but it starts the conversation going. So we also tend to inform women about this. Next slide. And then just very quickly, obviously, we're very pro of keeping, informing women about keeping active, because we know that keeping after, obviously decreases the risk of gestational diabetes and overweight. And obviously that in itself puts a risk of the pelvic floor, and it makes labor and delivery a bit more difficult. So we give women advice about exercising safely during pregnancy. Next slide. Once, from our point of view, that will be like the package, in terms of prevention of pelvic floor dysfunction. But what happens during the postnatal period, we have a triage system, and then we go to the postnatal wards. And then for us, a risk is, we see every Oasis and forceps, women that have a baby over 4 kilos. Those are like a major risk factors for us. So, we're already identifying those women that might be at risk, but a normal sort of intervention on those women, we tend to talk to them about perineal care, wound care, pain relief, how to start pelvic floor exercises, when is the best way to return back to exercise. We know quite a lot of women are quite physically active, so they're like, when can I go back running, what is the best breastfeeding position to avoid back care. Everyone who has got a perineal injury knows that doing that first poo after birth is quite a tricky one. So we obviously give them all the advice about defecation dynamics. We work with the midwifery and the obstetric team, so we get a good package. And then in our world, in the physiotherapy world, there's always been a debate about what we do on that stage. Is it effective? As in, are women ready to absorb that information? And I think that it just depends. It's true that the women that, for example, have come to our antenatal class, it's nice to have a continuity of care, and somehow, because they have seen us in the antenatal class, they expect us, and then they can ask us questions. So and then if they have any problems, and they can go back on that postnatal. So from the continuity of care, is actually quite good. And actually, we did an audit of 120 women a few years ago, and sort of where we thought, okay, well, let's find out if the women want that service or not. And actually, 95% of the women wanted us by their side. I mean, it might be biased because we have what I call our yummy mummies from Clapham, you know, but you know, it's okay. There's other women that seek our services, so why not? So on the basis of that, we keep our service. And obviously when we go and see women, it just depends where they are. You know, you can sometimes go and see women and they're like half asleep, they just had the baby 3 hours ago, and we'll go, hey, how are you? Just have this information, there's a phone number. But yes, and I have actually put where to get our information leaflets as well. You can go to our clinical interest group, POGP, where all of our information leaflets are free and you can download, and actually they have quite a lot of information. Next slide, please. And, you know, so once they have the baby, you know, obviously we will see them in outpatients for, you know, either any incontinence, prolapse, urinary incontinence, dyspareunia, sexual dysfunction. So what are our tools of the trade? Obviously, we have pelvic floor muscle training. We have all those, you know, gadgets that, you know, people think about. You know, we are quite pro now in terms of advising women to use apps, and we now have the evidence from the ICS about recommending them. And then a few things that we use. So next slide, please. Just to give you an idea as well, that what you can expect when women come to see us is that the slide before, please. Can you go back? Just very quickly, that we obviously, when we assess women, we tend to sort of do a very standard questionnaire about pelvic floor symptoms, bladder, bowel, sexual. We get all the obstetric, all the past medical history, so we get a good picture of how the woman has ended up, and then we tend to do a vaginal examination. It is true that until they are 6 weeks of finished bleeding, we don't see them, but after that, you know, we can see them. And then we work very closely with our obstetric, you know, like our Professor Oteng is our lead for the Oasis Clinic, and Mr. Kelleher and Mr. Kunda are our urogynecologists, so we work very closely with them. So if women have like any problems with the perineal, sort of any wound care that might need anything, we will refer them on to them. Sorry, next slide. And then I want you to think about, because I think with pelvic floor muscle training, there is a bit of like misinformation as to what women tend to do, and I think everyone gives the information in a different way. But what I want you to remember is that pelvic floor muscle training refers to the performance of repetitive voluntary contraction of the pelvic floor muscles, including the external anal sphincter, and this is relevant for the Oasis ladies, that aims to increase the strength, the power, and that sort of automatic reaction that the muscles have before we have any babies or before we are pregnant. So remember that when we call them forward, pick up the babies, the pelvic floor muscles contract, like they react like a trampoline to any increase in intra-abdominal pressure. So when you're doing the exercises, that's the aim of the exercises. Next slide. And you know, obviously, you know, when you actually, you know, using the pelvic floor, that's the other thing that people said, oh, you can only use the anterior part of the pelvic floor. No, you can't. The pelvic floor actually goes from the coccyx into the pubic bone, and actually an effective pelvic floor contraction comes from the back into the front and takes the anal rectal angle up into the symphysis pubis joint. And the other thing as well is the reason that we examine women, and this is something that I'm very obsessed about this as well, is that it's only by digital examination that we know that someone has the strength, the power, so they're actually doing the pelvic floor exercises properly, and this intervention is going to be effective. Giving an exercise leaflet to women, sometimes, especially if they have a problem, might not be as effective. Okay, so we know that in the pregnant women, you having that discussion actually can work, you know. In the postpartum, someone who's got a pelvic floor dysfunction, you need to examine women. And for that, we do a vaginal examination, where someone with an Oasis, I'll probably do a rectal examination. I have a feel of the sphincter. Next slide. And then if you click on the yeah, so you can see that if you click again, you can actually see that's a pelvic floor. Go back, sorry, and click. There we go. So that's a beautiful pelvic floor contraction. Yes, it goes from the back into the front. Okay, and this is actually very important, especially in the acute postpartum period, because especially after giving birth, you know, if any of you has experienced it before, when you have a child, you know, it's like your pelvic floor is non-existent. So the stronger part is your posterior compartment. So that's like, it gives you that sort of light at the end of the tunnel, right? So, you know, starting that pelvic floor contraction from the back is going to be the most effective way. So next slide. And again, so when we examine women, we create their own individual regime. Okay, so whereas when we are on the wards, we go for a very conservative, try to hold 10 seconds, do 10 quick ones as a standard advice, just to keep women going. But actually, at some point, I always go along with it. It's important that we do the pelvic floor marathon. Yes, especially after childbirth. And I always say to my patients, do you want to do the pelvic floor half marathon, full marathon? Yeah, or do you just want to do a 5K? Yes, because that's the amount of effort that you need to put. And it's very important that women understand that in order to change the muscles, you need good 6 to 9 months of, you know, intense training. And that's what makes the muscles change. You know, doing the exercises every now and again, or, you know, oh yes, I can do it anywhere. I can do it when I'm brushing my teeth. No, you can't. You do have a problem and you need to spend the time. So actually agreeing that sort of time where you're going to do it is actually very important in terms of the adherence to the exercise programs, but it needs to be for a bare minimum for 5 months. And, you know, it's very good when you just have the baby to do it sitting down, because obviously getting into feed the baby, either breastfeeding or bottle feeding, you know, sometimes that in itself is a difficult task. So you need to make it easier. But at some point, I'm very much okay. So if you have problems doing, you know, jumping on the trampoline with your toddler, then that's where should we actually train your pelvic floor. Or if you want to go back to running, you know, that's what we need to train your pelvic floor. So you need to do the exercises, standing, moving, and this is very important. Those muscles are no different from any other group of muscles. So the muscles need to be challenged in order to change. Next slide. This is actually very important, and we did a bit of a focus group a few weeks ago with our women, and actually the neck was, you know, they said to me that was the most useful skill they learned on that day. But actually the neck is, we asked the women to, you know, contract the pelvic floor before any activity that makes them leak or have a feeling of the scent of the pelvic organ prolapse, you know, and so it's actually contract before you know, in this case, lift the pram up or lift the baby or coughing or sneezing, and that in itself is enough to manage the urinary incontinence and prevent further descent of the prolapse. Next slide. Oh, I'm running out of time, I'm sorry. Postnatal exercise group, you know, again, it's very important, you know, you have a group therapy in general is very good, you know, from the camaraderie, and we have one at St. Thomas's that we actually referred after we have seen them. And again, you know, it's, you know, the fact they're coming, they're doing the exercise in a structure, you know, we tend to assess them vaginally before we refer them to the group, but actually doing exercise pelvic floor as part of a general exercise is actually, again, effective. Next slide. And these actually infographics are really good, and it just gives quite a lot of information about you know, exercise in the postnatal period. For me, exercising is actually very important as part of your looking after the mental health of these women, because we know that pelvic floor dysfunction is the main barrier to return to exercise. And for some women, you know, exercise is the way how you release the stress, how you feel back to your normal self, right? It's that body image completely affected. So I'm very much as to how can we improve that you go back to that thing that you were doing before that makes you feel good about yourself and also help you from the fitness levels and from your physical recovery. Next slide. And then there is a good, you know, that this is actually something that was published in 2019, and it's been absolutely tremendous help for us. This is a group led by Grant Donnelly, which actually has given sort of a very structured way of assessing women in the postpartum period and providing a specific advice as to what they can or cannot do before they actually go back running, for example. So next slide. and you can actually download it for free. So if any of you want to, so it tells week 0 to 2, 2 to 4, 12 to 4. We tend to check the diastasis of the rectus abdominis, pelvic floor assessment, and with that we'll actually come up with a comprehensive exercise program to improve not only the pelvic floor symptoms but to return them to exercise. Next slide. Sorry, I'm running late. And then obviously sometimes on the examination, so for example, when we examine women and we grade the muscles, we normally grade them from 0 to 5. 0 means that there is no pelvic floor activity indicative of a serious neurological deficit, whereas 5 is super muscle. I always say 5 is before you have children. Most of us, the rest of us after children are around a 3, for example. But if someone has a 1 or a 2 and they find it difficult to activate, or they have less feeling, so that's when we will go down the line of using biofeedback or electrical stimulation. In the postpartum women, we wouldn't use electrical stimulation, for example, until at least 4 months postpartum, and that's just to make sure that there is an element of natural recovery that happens, especially from nerve injury point of view. Next slide. I'm very much, everyone gets their gadget nowadays, and they go with weighted vaginal cones. I just put these ones, but there is massive, there is quite a lot of cones. Again, cones is something that I wouldn't actually advise until someone is actually at least 12 to 16 weeks postpartum. Okay. However, a pelvic floor educator, which is actually the cheapest thing that you can buy in Amazon, is, one of the most effective, tools, because, it sort of gives that visual feedback that someone is doing the exercises correctly, whereas and then the amount of effort that you have to use in order to move the stick, it means that you're actually recruiting quite a lot of pelvic floors. It's actually quite good. Next slide. Apps, obviously in the NHS we recommend the Squeezy app, and from I was at the conference a few weeks ago, the International Continence Society, and we know now that using apps is an effective way. So when we examine women, then with the Squeezy we tailor what we examine on clinic to their Squeezy app, so they can actually do it, and then they can show us what they've been doing, and actually we can also monitor remotely what are they doing. So it's actually quite a good way. Next slide. Sorry. Next slide. There's the ELV as well. It's a bit more expensive. Some women find it quite useful. It's a biofeedback tool that you can buy, and it's under the NHS. Next slide. I'm sorry, I'm running late. I speak too much. Female devices, I'm quite a fan as well of, for example, if someone wants to go running in the postpartum period and they have urinary incontinence, then we will actually give them the Contiform or the Active Control, or, just feed them with a pessary that will allow them to go for a run. I think everyone gets, really hung up about running and pelvic floor, and actually lifting the pram various times during the day, getting out of the bed in the incorrect way puts equal pressure on your pelvic floor. So actually, if by putting a Contiform or a pessary, we allow women to go for a run and feel better, and then start getting that physical recovery, then of course I will recommend that. And next slide. I think I finished now. Thank you, and I hope that gives you a quick overview of what we do.
Thanks very much, Paula. I think, Sarah, were you going to take over?
Thanks, Paula. I certainly learned a lot during that very thorough talk, and as a mum, it was particularly refreshing to hear about your views on education with these potential injuries pre-birth, especially for first-time mums. I now hand over to my colleague Julianne Moore, partner in our Sheffield office, for the first of our Q&A sessions. Thanks for all our speakers so far. Over to you, Julianne.
Thank you, Sarah. Thanks very much, Sarah, for that, and it's been a really interesting morning so far. So we've built in a very short Q&A just before the break, because obviously some of our speakers who've kindly given their time can't attend the panel discussion because of clinical commitments. So we're going to keep this section pretty short, and most of our speakers are able to attend the Q&A at the end. So mainly, Paul, I've got some questions for you, if that's all right. One of the questions that's been posed is, what is your experience of women's health physio in the NHS, and are we getting the best outcomes for women? I mean, what I've heard from you, you've got a fantastic service at Guy's and St Thomas's. It just sounds amazing. And I don't know whether that's being replicated across NHS trusts up and down in the country. So, what is your experience? Are we getting good outcomes? And your experience, in dealing in this field?
Well, I think, I have mixed feelings, and it does look that we have a good service, but like the rest of everyone, we have a huge backlog. Okay, so it's not all shine, yes, but yes, I think we've been very lucky. I have to say that, we have very good supportive consultants that have actually allowed us to do this, and I think that joint MDT work, is actually very important. I think that when I look at other colleagues, for example, the role of a physio in the obstetric wards, for example, most physios will feel quite good to go and inform women, whereas sometimes that's the first thing that goes is a scrub. And in fact, one of the reasons why we did our audit is because they want us to take us out of the obstetric wards in order to do more outpatients. Yeah, so we asked the women, what do you want? So I think it's there is a big inequality when it comes to pelvic health physiotherapy across the UK, but that's the reason why the pelvic health implementation, project is going to be very work to bring the standards. What are the basic standards that all maternities should have? Obviously, we were appointed, so we are actually developing that with a project manager. And but yes, I think that's the problem with pelvic health physiotherapy. There's not that many of us. When people do physiotherapy, they want to go into sports, very boring, and it's not many of us, and but now we have such an overwhelming evidence, like the NICE guidelines are about to be published for pelvic floor dysfunction, for prevention and management. Again, that is going to change clinical practice. For example, that's going to hopefully give to the stakeholders that at least they're going to be needed at least 3 more physios per maternity. So I think that is going to make a difference, from that point of view. I don't know if I'm answered the question, or I'm going around in circles.
No, that's fantastic, and certainly, I sort of drew from your presentation is all that sort of education that you do in the antenatal period, and we often know, isn't it, is actually informing, patients, ladies, families, etc., and equipping them can help with prevention later on. So actually, it's usually more cost effective, not only in terms of the actual care that's needed in the postnatal period, which might be more complex, but as we've heard from Ashley, that human cost that doesn't get factored into that. So I think it's absolutely fantastic. One of the other questions that we had posed, which I think you've answered, was whether or not you thought perineal massage in the antenatal period makes a difference to perineal trauma, and I think you kind of answered that one during your presentation. I don't know if you want to add anything else to that.
No, and I think it's important because some women, I always say to everyone, I think perineal massage is like Marmite. Either you feel it or you don't feel it, right? Either you want to do it or you don't. So it is important, if you want to do it, you are consistent, but perineal massage goes in line with best position, so many things. So it's important that women are aware of that.
Fantastic. I've got another question that coming hot off the press here. So another question for you, Paula, is what is your experience of private insurers covering the cost of women's health physio?
I only work on the NHS nowadays. It's very tricky to get the insurance to pay for pelvic floor physiotherapy, and it is tricky. So most patients actually go completely private. It's not fair because it's I think you saw it on the news a few weeks ago how one private insurer in particular didn't want to pay for physio because it was a consequence of your own choices of having a child. So it's a very tricky one. It needs to change as well.
Definitely. And then another question that was posed through is in terms of the risk assessment that you've developed. Is that something that you developed in Guy's and St Thomas's, or is that something that's used nationwide?
No, it's actually we have actually established it as part of the perinatal pelvic health project, because we're working very closely with the midwives, and for me this has always been very important, because I can raise the flag of physiotherapy, but I'm very clear that every single woman will see a midwife, not everyone will see a physio. So getting the midwives up to standards with what it means to have pelvic floor dysfunction, they're so busy, and that's what we know. So part of our project as well is going to train them into what is normal, what's not normal, and what you need to do about it. And so the pelvic floor tool that we use is actually one from Frimley Park. I'm happy to sort of email it to you if you want to use it. There is on my presentation, there is also a reference from the Nursing Times in 2007. There is a Promocom pelvic floor tool that we used to use in the past. It's a very simple tick box. Did you have urinary incontinence? So I think and we have actually embedded that into what we call BadgerNet, like a digital form. So it's now part of the 12-week assessment with your midwife to go through your pelvic floor questioning. And actually, if you have already signs of pelvic floor dysfunction, go to physio, and then discuss with obstetricians, so it's already, we're already happening. Obviously, we haven't had any data now, and it needs to be embedded and change in practice, but, we'll hope that in the future, that's what should happen at a national level.
That's great. And just one final question for you, Paula, because I'm conscious of the time, is that something that's just come through. The question is, are you sure that exercise prevents GDM? They may have misheard.
GDM?
GDM.
Like diabetes?
It's not very clear.
Yeah, I'll have a look on the.
You can see it's at the bottom of the chat. It's that last question.
What I'm sure is that obviously exercise, we know based on research that exercise decreases the chances of you developing GDM, yes. And actually, if you do have GDM, exercise is one of the interventions provided to women. So we know that that's the national guidelines.
That's great. Thank you very much. Andrew, are you going to be available on the panel discussion? Because I'm conscious of time, and we know we had some fantastic questions for your good self. Are you going to be able to come back to the panel discussion?
Yep, that should be fine.
That's great. I think what we'll do is we'll end the short Q&A there. Everyone can go off and have a break. And if we probably look to return for about just for 5 minutes at 11:30. And thanks to all our speakers so far. Most of those are going to appear on the panel discussion, so everyone can go off and get stretch those legs, do those pelvic floor exercises for us ladies in the audience, being included.
All the way.
Definitely, and we'll start back at 11:30. So thank you very much again, and please continue to send your questions through on the chat, on the Q&A function as well. Thank you.
Thank you very much.
Welcome back, everybody. The speakers in the first half were incredibly insightful, and we're really excited to share the second half with you going forward. To start off the second half of today's webinar, I'm going to hand over to Sarah Davison, who is one of our incredibly inspiring clients who's willing to share her story with us today. And she's going to be joined by Shivi Nathan, a partner from our London office who represented Sarah on her legal journey.
Hi everybody. So Sarah was one of my clients who came to Owen Mitchell after reaching out to the Birth Trauma Association for help and support. And as you'll hear when she shares her story, Sarah is an absolutely remarkable woman who not only faces the day-to-day physical and psychological impact of her injury, but also had to endure the trauma of a contested trial. So Sarah's injury meant that she was unable to continue with her career, and in her case that was disputed by the defendant, who argued that she would never have returned to work after having children. So not only did she have to relive her experiences in a courtroom, but she also had to defend her position under cross-examination, and she did defend it successfully and won her case. So I'm incredibly pleased that she's agreed to speak today. It's so important that you hear her story and hear the impact of birth trauma and what it does to women, their families, their careers and their lives. So Sarah, I will hand over to you. Thank you.
Thanks, Shivi. I'd like to start off by saying how humbled I was by Ashley's story. Brings tears to my eyes. My experience was far less severe, so I'm going to try and fill in some of the blanks that maybe Ashley didn't, in terms of the pain and anguish of the surgery and the aftermath. My experience of birthing trauma stems from a midline episiotomy that extended. It was either misdiagnosed, certainly wasn't communicated at the time of delivery, and it wasn't represented in my notes, and then it was inadequately repaired. We had had a very uncomplicated pregnancy. Our baby, our first son, who's 13 next month actually, presented in the OP position a few weeks before delivery, but we were told not to worry. It was no worse than trying to fit a left shoe on a right foot, was the quote that I will never forget from the time. When I was admitted to hospital, I had an epidural very early on. My membranes were artificially ruptured, and I then went on to have a 14-hour labour with a prolonged second stage. All of this guided by midwives. My obstetrician was largely absent until the next morning, at which point our son's heart rate started to weaken, and so intervention by way of an episiotomy was recommended. There was no discussion at the time about the different types of episiotomy. It's not a subject I recalled a great deal about from our NCT classes. I certainly feel now, having listened to Paula, that I would have benefited hugely from meeting someone like her beforehand. So we agreed to the episiotomy because when the urgency takes over, you're relying on the professional to make the right decisions for not just for you, but for not just for your baby, sorry, but for your own personal outcome. And I think that, you know, the post-mortem of our case with Erwin Mitchell revealed that just wasn't happening. So our consultant obstetrician performed a midline episiotomy. When I refer to NICE guidelines, which I do from time to time, it's my knowledge of what they were at the time of my case, which is 2008. And we closed that out in 2013, I think, Shivi. But NICE guidelines favoured a mediolateral cut based on the body of evidence that lines just increase the risk of third and fourth degree tearing exponentially. And certainly, just harking back to Mr. Farkas's presentation, we had a number of aggravating factors. It was a first vaginal delivery. It was a long labour with a particularly prolonged second stage. We had an OP baby. I'd had an epidural. You know, it was almost a textbook case. It should have raised some flags, certainly in my mind, with all of the scrutiny that we've done with what happened. My son was delivered. Our obstetrician, Mr. Craig Leach, failed to diagnose and then report what had happened. My notes described a small midline episiotomy that extended slightly, and the notes that accompanied it, which were incredibly brief, suggested a second degree tear. What we later discovered after I'd had an endoanal ultrasound and an anorectal physiology test was that I had a full length tear to the external sphincter and a damage to the internal sphincter running most of the length of the canal. As a result of the breakdown of the repair performed by Mr. Leach, I have virtually no sphincter between my rectum and vagina, no perineal body whatsoever. So this is February 2009. I was 31. I was totally incontinent. NICE guidelines at the time, I'm sure they still do, recommend that a rectal examination is performed before and after the repair, but my notes showed that no such examination had happened. My repair, again, this was interesting listening to Mr. Farkas, my repair was performed in the delivery suite by the obstetrician on his own with no additional lighting and no further assistance. So I think within 12 hours of delivering our son, we were discharged from the hospital. I had no idea about the gravity of my injury, how severe it was. There was no antibiotic cover. I left with a prescription for lactulose and a sheet from the physio department about how to do my pelvic floor exercises properly, and that was it. And we had 2 weeks of blissful ignorance at home before the repair broke down. I was sitting on the loo. My husband had just gone for a run, and Freddie was in his cot. All of a sudden, everything just gave way. The pain was intense. In the 13 years since, and I've had 2 C-sections, I've never seen so much blood. I I had no idea what was happening. I was incredibly scared. I had to stay on the toilet until the bleeding had stopped, which was quite some time. And obviously during that time, Freddie started to come round, of course, always the way, and was getting increasingly agitated. But I had a community midwife appointment booked in for the next morning. So I just resigned myself to let her assess it and then plan from there once the bleeding had stopped. Amazingly, she reviewed me the next morning and thought everything looked okay. There is no way it was, but I really wanted to believe her. So we kind of persisted for a week or two, but in the end, I couldn't ignore the pain. I had a low level, constant ache that just got worse. And obviously the incontinence, which I think in my mind, I was hoping and praying was short term and delivery related, not related to an injury. So we eventually got back to Mr. Leach, who then referred me on to a colorectal surgeon called Mr. Richard Cohen, my saviour. After listening to Ashley, I really believe that. He ordered the test I referenced earlier, but the test results I thought were the worst of it at the time, but the waves kept coming. Mr. Cohen explained to me that what he would like to do was wait 6 months before any repair was undertaken to allow for a certain amount of natural healing. When you're 31 and you're totally incontinent with your first baby, and you're worried about relations with your husband, you're worried about your self-confidence, your self-esteem, being told that you have to wait 6 months is just, it's hard to comprehend. It's hard to get your head around. He also said that he wanted me to consider having a stoma to cover the recovery of the surgery and give my rectum some space to heal and recover. Probably don't need to explain how that made me feel. I went through the motions. I went to see a stoma nurse. I did a lot of reading up about it. I spoke to family members who had had them or knew people who had had them, and I just couldn't, while there was even the slimmest chance of having the surgery successfully without a covering stoma, I had to say no to it. And I encouraged him to bring the surgery forward, and we agreed on 3 months post-delivery. But the burden of going against a specialist recommendation in that situation it weighed heavily. You know, you don't know who to trust, you don't know what to trust. You just have to put your best foot forward. Anyway, so we went on to the surgery. I had a sphincter overlap repair, and that was done in March 2009, so about 3 months after I'd had Freddie. I think this is why listening to Ashley made me so upset, because I had one surgery. It was the most painful experience of my life. She had 6. My heart goes out. I was in hospital for 2 to 3 days, and I was bedridden for 4 to 5 weeks. For most of that time, it felt like I had a dagger between my legs. I had a weeping wound. There were days when I did not think there would be any relief from the pain. It just seemed to go on and on, day after day. But what I wanted to touch on with this is not just the pain, not just the personal anguish, but it is the logistics of trying to fit this sort of event into a busy life. My husband worked long hours in an industry where, you know, leave is hard to come by. It was our first baby. My parents lived abroad. Imagine a single mother, a woman in an abusive relationship. Any number of scenarios would have been worse, but trying to fit in 4 weeks of bed rest and recovery with a new baby, I don't know how that we would have got through it had my mother and father not moved in with us. And they did. They moved in with us for the full recovery period. They did everything. They nursed my son. They looked after me. My mum cleaned my scar in between health visitor visits, looked after my husband, you know, made his food, changed our bed sheets. How does any of that happen if you are alone, if you don't have a support network, All of these factors, I think, are seldom considered. It's all very clinical. It's how are doctors trained? What should our response be? We need to start thinking about how women actually recover from these events. And it isn't just a physical recovery, it's a psychological recovery, it's an emotional recovery. And I think one of my biggest coping mechanisms over the years has been gratitude that my situation wasn't worse. Because as bad as it was, I knew that there were far worse stories out there. And, you know, Ashley's was testament to that. I'm still with my husband. He's been amazing. I'm immensely grateful that Freddie was fine, healthy, and has thrived, because I think being able to walk away from a situation like that, two of you and at least one of you be okay, you know, that was a win for me in that situation. So I can't labour the point enough about how much it affects you emotionally. I wasn't sleeping. Intimacy between my husband and I disappeared for the best part of a year, especially with the surgery during that time. I felt withdrawn. I withdrew from people. I was jealous of other mums who seemingly had no issue, my friends who seemingly had no issue. It removes you from what should be a very joyous point, a joyous milestone in your life. It changes it all, and I don't think you ever really get over that. And the same can be said for body image, self-confidence. You know, my husband and I are tight, but I wonder where we would be had this not happened. You know, my self-esteem, I don't think will ever be what it was. After the repair, we had a long period of recovery ahead, but one memory that really sticks out, and again, this is something I really want to try and convey the detail of, was trying to re-establish function after having an overlap sphincter repair was horrific. I spent 2 hours in the bathroom with my mum, trying to squat over the toilet to go. I really needed to go, but I couldn't. I remember lying on the floor, sweating profusely, in tears. At one point, my mum said to me, maybe it would help if she put her finger in my rectum to try and encourage some movement. And it was one of those out-of-body moments that you have. You don't understand why you've fallen so far so quickly. How did I go from being fit, healthy, strong 6 months ago to lying on the floor in my bathroom with my mother offering to put her finger in my bum to help me go to the toilet? How does that happen? Why does that happen in this day and age? It's not good enough. It's not good enough. In the end, she had to phone Richard Cohen's office and they put him through to me on the mobile, and he talked me down. He brought me down off the ceiling, and we got through it. But that's a memory that's obviously never going to fade. And you can tell, I mean, this is 13 years ago. I'm talking to you about 13 years later. It still makes me well up. A lot of this still makes me well up. But going on from that, I've obviously had 2 other babies. Again, grateful that I could do that. They were delivered by C-section. Again, harking back to Mr. Farkas, Richard Cohen advised me that he couldn't guarantee, if I had any further problems and I needed a second repair, he couldn't guarantee how good it would be or what function I would be left with. So, you know, whilst there is an element of choice, it is left up to you. There is a steer, there is an emphasis, and who wants to go through that again a second time? No one would want to go through it once, let alone 2 times. So both of my second babies were born by C-section, both blissful experiences by comparison, I would have to add. I've regularly sold bed sheets, clothes, had accidents whilst out and about. We moved to Hong Kong about a year after I had Freddie, and I was at the gym one day with a personal trainer, and I pooed myself. I couldn't stop it. Just had to leave. I don't think I ever went back. Tampons would regularly fall out. I've never been able to control wind, even to this day. Living in a house with 4 boys makes that a bit more bearable because we just joke about it, and often that's a coping mechanism. We just laugh, but a lot easier to do that at home with your family than it is in public. I have times when I want to go to the toilet, but I can't evacuate, and equally I have times when I have to dash. So over the years, I've managed this with changes of clothes, keeping them with me, wearing dark clothes, wearing sanitary pads to give me a bit more time. I've obviously had bouts of physio, but that is a constant challenge. And I do wonder if that's why the quality of Paula's outfit is not seen more broadly through the physio is such a difficult thing to stay engaged with and keep doing well, especially when you're dealing with a subject matter that is so sensitive and so deeply entwined with sexuality, confidence. It's, you know, to a large extent, a muscle that most people don't realise they're using most of the time. So really to try and engage with that is always a constant challenge, and I think progress isn't always a straight line. But what I do realise is that, and I'm sure a lot of women in my position would agree, you're very much at the mercy of facial consistency most of the time. The looser it is, the more vulnerable you are. And you can manage that to an extent with diet. So what I found is my eating habits have become very habitual. I take a lot of confidence and reassurance from knowing how certain foods will affect me. But obviously hormones play a part there. And so I often struggle around periods. But I think it's a case of, as you go through the years, knowing how your body responds to certain stimuli and just adjusting your own processes. And I think what worries me the most going forward is just the burden of time. Obviously, menopause is going to bring muscle laxity with it. And when you're already heavily compromised in a certain area, you don't really know where that's going to leave you. And you won't know until things start going really wrong. But the best you can do is just try to stay as fit and healthy as you can, which is what I invest a lot of time in. I go to the gym a lot. I have a trainer. I have a women's health physio. I have a general physio. I've just become obsessed with trying to make my body function as well as it can. And, you know, just a closing thought as I prepared for today, I've realised that I have surrounded myself since the time of my injury with female practitioners and specialists. The rational part of me tells me that this is pointless, and it should be pointless, but I lost trust in the medical profession, and specifically in men. My obstetrician was a man. Yeah, I'm just going to put that out there. I lost all trust. I gave a talk from Erwin Mitchell at a BTA event a few years ago, and the vast majority of attendees were female. Maternity improves when issues are better understood, and that comes from taking an interest and being present and listening. I hope today has given you some interesting takeaways. Thank you.
Thanks, Sarah. That was a really powerful story, one that I've obviously heard before. And I hope that has had an impact on the delegates listening, and I hope there are some takeaways from that. So thank you so much for sharing that, Sarah. Thank you. Sharon, back over to you.
Thank you so much for sharing your story. It was incredibly personal and emotive and incredibly brave of you. Thank you so much, and the incredibly articulate way that you've shared the effects on yourself and your family today lead us very nicely into our next speaker, who is Dr. Jan Smith. Dr. Jan Smith is a registered chartered psychologist, and she's also the director of Healthy You Limited. Jan Smith is part of the NHS Leadership Academy and provides leadership and coaching within the healthcare industry. She's supported clients who've experienced birth-related trauma, and she also helps and supports healthcare staff who suffer from vicarious trauma as well. Jan has written and published about the impact of moral injury and vicarious trauma on staff, and as well as preventing birth trauma in maternity. So I'm going to hand over to Jan now. Thank you.
Next slide, please. So I am going to very quickly in this 20 minutes talk about the causes of birth trauma, some of the symptoms related and the impact, and also for those listening today, whether you're healthcare or working in litigation, the role that you can play in supporting birthing women and people. Next slide, please. So there are many things that can cause birth to be experienced as traumatic. Some of these might seem very obvious, like interventions. However,
I think with birth trauma, there's a misconception that if you don't have an obstetric emergency, that it isn't experienced as traumatic. And so I think it's worth holding in mind that in the absence of having an obstetric emergency, that you can still experience birth as traumatic. So Cheryl Beck very aptly coined the term that birth trauma is in the eye of the beholder. And of course, physical birth injury is something that can be significantly impacted on how someone experiences their birth. What I would say is not everyone who experiences a physical birth injury necessarily experiences their birth as traumatic. It can be the experience and managing the physical impact postnatally and the experience and journey throughout that, through diagnosis, getting a diagnosis, also through treatment, that can be the source of their birth trauma, or their trauma rather. And what I also, I guess, describe trauma as is that you have the core incident, which in this case is birth. And it's almost like an onion. Then you have layers on top of that that can compound either that core incident, or can re-trigger and re-traumatize postnatally those symptoms and compound those symptoms of trauma. Next slide, please. So, I mean, Ashley and Sarah, you've so powerfully and eloquently and very movingly shared your experience about the impact that physical birth injury has, and the range of clients that come to see me who have been impacted physically and psychologically by their birth share a full range of psychological symptoms that have a ripple effect, and that's the way that I describe it. It's a ripple effect that filters and infiltrates areas of your life that you didn't even know were there. And so there's a real hidden part of physical and psychological birth trauma that we don't talk enough about. So in Sam's account, what she has shared is feeling trapped in her own body and the heightened anxiety that that brought. Also, which has been touched on previously, not being aware that birth can result in life-changing injury, and wishing, which I hear so much from women and birthing people, about wanting to have been better informed that this is a potential outcome. There's much discussion within the birth world about protecting pregnant women and women, about not scaring them. And in my view, women can make that decision themselves. They're adult women and they very much want to know this information. Now, this isn't saying that it's going straight to, look, you potentially could have a physical birth injury, these are the range. I think birth is on a continuum. Do you know, you can have the water birth, the candlelight, the Zen experience that you maybe want, and the other end as well, and everywhere in between. And it's mostly the everywhere in between that people generally land. And I think in not doing this and in not giving birthing women and people this information, it means that, first of all, they're not informed when in those moments of having to make decisions, like Sarah has just shared. You know, you don't have that information in your mind to even have that conversation with your partner about, is this something that we could do? Is it something that we could manage? So having that informed decision making can start way before birth. That can start antenatally. And as well, it means that whenever in those early days postnatally, because this often isn't in women's minds that it's a possibility. It means they don't look out for signs, in my experience, and they usually reach out when it has reached a critical place. Do you know? So there's also the potential of delaying the diagnosis, and it serves to isolate them even further. And that loneliness of, you know, Sarah was sharing there, hoping, fingers crossed, everything, just hoping this is birth related and not something more longer term. So I think we have a real responsibility to share and openly discuss with birthing women and people about the implications that birth can have. Next slide, please. So the symptoms of birth-related trauma, there's some evidence that does suggest that a history of psychological problems or a prior trauma, as I mentioned, obstetric procedures, or negative interactions with care providers, so staff, can contribute to experiencing the birth as traumatic. As Ashley shared at the beginning of the webinar around the impact that it had on bonding with her baby, and also inevitably the relationship with partner, with friends. What I also, you know, say to clients, it's the relationship with yourself. Do you know, it's the relationship of what makes you feel like a woman. Do you know, clothes that you wear that make you feel confident as a woman, make you feel in a way that that's part of your identity. When that is altered, which motherhood does tend to do anyway, but when that is altered, that has a significant impact then on your confidence and your self-esteem, your body image and your identity, and how you relate to yourself in that way. So some symptoms of trauma, the core ones are heightened levels of anxiety, and anxiety is probably the most prevailing symptom that people reach out. Nightmares about the birthing experience, avoidance of places, and what I would say is that which Sarah and Ashley both touched on, is that physically, as women recover from the initial impact of birth, she may or may not realise that our symptoms aren't residing as they should be, especially if she is perhaps doesn't have that support network around her, or doesn't have other peers that she can bounce off. How was this for you? And the psychological symptoms of birth trauma often lie dormant. So we know that women and birthing people who experience their birth as traumatic, usually it's 6 months postnatally when some of those psychological symptoms will start to arise. And so in adjusting to living with physical birth injuries, this can potentially trigger and compound the birth-related symptoms even more. So it's worth bearing in mind that if you see a woman or birthing person in those early 6 months postnatally, and they may not be displaying some of these symptoms, that isn't necessarily just ticking the box to say, actually, psychologically, they're probably okay. This is checking in regularly and creating opportunities in that trust and relationship to be able to check in how that person is, because it's not just 6 months or postnatally. This can lie dormant for years. And you know, I've had the eldest client I've had came in her 70s. She had a birth trauma. She managed it as best that she could, but something happened in her 70s when she lost her partner, and that triggered her birth trauma and those symptoms then all those years ago. Next slide, please. So as I said, transitioning to parenthood can often be a time of adjustment in relationships, And the added layer of psychological trauma and physical injuries place significant strain on relationships. And for many women and birthing people, when they should have been embracing motherhood and what that meant for them, they can feel that their birth-related symptoms have massively overshadowed that transition. So often, you know, how they perceive maternity and also how they want to have their decision making and having future children can be massively impacted in that transition period also. So again, whether healthcare or working in litigation, you have a significant role potentially in supporting that person in that transition. So not feeling believed or dismissed can also significantly affect adjustment to birth trauma and also physical injuries, and that can lead birthing women and people to internalize those symptoms, so thinking, oh, it's just me, no one else is experiencing that, and that can increase their sense of loneliness and isolation. And given the interpersonal nature of birth-related trauma, social support, we know, is a significant protective factor postnatally. And an increase in postnatal depression 6 months postpartum has been reported in some women experiencing incontinence. And so feeling anxious about, you know, needing frequent trips to the bathroom, shame surrounding symptoms, or being self-conscious that you might leak or create an odour, that tends to get internalized by many women, and so they tend to socialize then from friends, going out in the community, or even thinking about returning to work. So a time when they need the most support and actually increase support, that's when they're more likely to isolate. And you know, there's a huge part where we talk about if you're struggling, if you need help, reach out. Personally, I think there is a massive, massive part of that conversation and narrative that is missing, which is about, we all have a responsibility to reach in, you know, to reach in to people, to reach in to women and birthing people, to create those opportunities, to just check in, how's it going? And so it's really, really important not to always put the onus on the client or the woman or birthing person to reach out when they need support. They may not even know they need support. But that offer, that opportunity that you create in your role can be life-changing and life-saving in many situations. It's also important, which was discussed this morning by Mr. Farkas, that to remember that other injuries, which perhaps are not so easily diagnosed, also significantly impact on women's lives and their families. And what I always say, which I really heard coming through when Sarah shared her experience, is it's not as bad. It's not as bad as that other person. Other people are worse. And what I always respond to that is, this is your world, this is your family, this is your life. And so it's trying to catch that doesn't minimize your own experience and your symptoms. That can help sometimes, but it's also catching you're totally deserving of that experience of reaching out and receiving the support. Next slide, please. So many women that I see and hear over the years have shared how they feel irreparably damaged, and we know the evidence and the research supports this as well, and that their lives have been ruined. They will never be the person that they were pre-birth. And trying to support them in their journey of recovery to know that part of them is not their trauma. They are not their trauma. They are not their physical injuries, they are not their birth-related psychological injuries either, even though they might feel that they are. So a huge part of recovery is trying to support that birthing woman and person to really catch some of what made her identity previous to her birth. So we know that, again, the psychological impact is on a continuum. So what I always share with clients, you know, it's not that some of these symptoms you have to be feeling at the most extreme end of the scale. It's also, you know, starting to feel some of these that can be a sign that you're being impacted by your experience. Shame and embarrassment. So we know that when shame and guilt and embarrassment are at the core of psychological distress, as human beings, what we tend to do is we tend to revert in, we tend to go small, we tend to internalize, and actually that's the time that we need most support. And so that's why I would really, really urge all of you to, you know, to reach in, to make that concerted effort to reach in to clients and women, to offer, to create an opportunity. Friends, do you know, if you have friends who are new parents who have had a difficult birth, do you want a cup of tea? Do you know, it doesn't have to be large acts. It can be just creating that opportunity to reach out. Anxiety is probably, as I said, the highest thing that I've seen. That could be constant check-in, constant you know, trips to the bathroom when the client may not necessarily need it, but just getting into what we call safety behaviours. So a huge amount of safety behaviours where their anxiety is high, and so they will perhaps go and check. And what our brains do really good jobs of is making associations really quickly. So over time, and even some clients that I've seen a couple of weeks postnatally will have already safety behaviours in place, you know, because they've heightened levels of anxiety, they're sleep deprived, so we know that that will massively exacerbate the symptoms, and also that they will associate a reduction in their anxiety by doing some of these checks. So what I often talk to also just on that point, you know, clients will also talk about how in those first 6 months as well, they might be misinterpreting what other people are saying. So they might be getting looks from people in the community when actually that isn't that may not actually be happening. And it's really important that an increase in oxytocin in the hormone, especially if you're breastfeeding, is really great in the sense that it cues you to your baby and makes you, you know, be able to really connect and tune in with them. But that heightened oxytocin also means that socially you will be more astute and pick up more cues socially from other people. And when you're sleep deprived, you're managing physical and psychological injuries. There is a risk that those are misinterpreted, but that can compound. So when we go back to that trauma and the layers, that's something that can also compound some of those symptoms. Grief can be experienced by individuals with physical and psychological birth trauma, and that might be attributed across many areas of their life. For example, grieving the loss of not feeling able to have future pregnancies, the person, as I said, that they were before the birth, as well as not being able to pursue some hobbies or activities they once did, or their work. And those feelings of grief might present as low mood, anger, sadness, or loss of hope about the future, which Ashley touched on this morning. And it might be that similar feelings, as I said, are triggered or resurface at significant points in someone's life, like losing a loved one or transitioning through the menopause. So that's also where I get a lot of referrals from clients when they're noticing changes related to the menopause as well. Next slide, please. So often women can feel, as I said, that they're the only one experiencing physical and psychological injuries. So signposting them to organisations that can offer support and resources for them can be really empowering, because it helps them realise that they're not on their own. Don't underestimate the power you have in your role, because psychological healing doesn't have to begin when they come and see someone like me. It can begin at that first appointment that they have with you. When a mismatch occurs between what health professionals' opinions are of women's experiences, that can feel understandably really humiliating and disheartening. So therefore, it's crucial to be able to listen to women and birth and people's experiences in that openness and empathy, ensuring, of course, to take a thorough medical history, while also being aware of some of the red flags which might indicate the physical and psychological trauma that they've experienced. Following a birth trauma, an individual is likely, as I've mentioned, to experience triggers, and it may feel like they are re-experiencing the incident or part of it, and have those intrusive thoughts and really feel flooded with those difficult emotions, like when Sarah was sharing that experience and that memory that came to mind for her of being in the bathroom with her mum. I mean, that is overwhelmed. That word feels redundant, but I think as well it's noticing and being aware of what some of those triggers might be for clients. And it's essential to be aware when discussing birth, examinations, language that you use, and subsequent treatment that could potentially be triggering for women. What I always encourage, you know, whether you work in litigation or healthcare, is to ask clients whether there are any words or statements or actions that you should refrain from, or any indeed that they prefer. Because sometimes, you know, there are words that were said either at the birth or postnatally that are really embedded in their narrative of trauma. Also, when individuals disclose their trauma experiences, responding with compassion and also acknowledging that their feelings are valid and that they're not alone, and that you're going to be there supporting them if you're able to. If you're not able to, don't offer that, because I think what Sarah was mentioning as well, the lack of trust. And what I hear from a lot of clients is that that trust and lack of trust then can become generalized, where they're mistrustful of lots of people, not just healthcare staff. So when I say that in your role, healing can start in that first appointment, you totally can and have the power to do that. Next slide, please. Thank you.
Thank you, Jan. That was incredibly thought-provoking, and I could see many of the comments that you were making were really resonating with Sarah, and I'm sure many of our other delegates today. Just before I move on to our next speaker, just a quick reminder that if you've got any questions for any of our speakers today, please do add them to the Q&A, and we will deal with them in the panel discussion that's coming up later. But next of all, we've got Sue Bryden. Sue is a recently retired midwife who worked for over 40 years in clinical practice, and she's also been a lecturer as well. She has regularly represented our claimants and our clients in clinical negligence cases. In clinical practice, Susan was considered an expert in perineal repair, and she actively sought out every opportunity to share good practice through teaching and training. So Sue, over to you. Thank you.
Hello. Oh, hi. Well, I'd like to start by saying that I'm really happy to participate in the session. And I only hope that I can add something that is going to be a bit thought-provoking. When I started to think about what I was going to say, I was going to have slides and horrible pictures and lots of research and statistics, but I actually don't think that's necessary. I think that Andrew covered quite a lot in his presentation, and I've been incredibly moved to listen to Sarah and Ashley. And they're not stories that I've never heard before. I've heard several of them either through my medico-legal practice and in my friendship group and at work. I'll just start by having a little romp back in history, because I've been a midwife since 1980, and obviously I trained before that. And when I started my career, there was a very different attitude to perineal trauma in prevention, repair and aftercare. I think there aren't any figures to support what I'm going to say, and I don't think there's anybody else in the audience older than me to argue with me. But my recollection is that in 1980, when you came to work on a postnatal ward, there were loads and loads of women all sitting on their rubber rings and shuffling around the ward like old ladies, and they just waited for the swelling around their silk sutures to subside over days, and then the midwife would come along and dig them out with forceps and cut them out. And this just seemed part and parcel of the birth process. Now I know, listening to Janice, that actually some women do suffer trauma in those periods of time and carry it with them for years and years. And one of my own friends is fecally incontinent and has never been diagnosed with anything, and she's now in her 70s and has put up with that all those years. But there was a general feeling that that was part and parcel of how birth went. Not third and fourth degree tears, but certainly perineal trauma. And I'm really glad that actually it isn't what people expect now, and they want more from life than putting up with, ruined relationships and all the things that Sarah described and Ashley. I think there's been a significant improvement in the recognition and repair of perineal trauma. Back then, and it's hard to comprehend, but I know for a fact that people didn't get training, midwives didn't do any suturing, and we used to grab a medical student who'd done basic surgical skills, and he'd be dragged into a room. He'd be, only 20 at the most, 21, and he'd be faced with a scene from a battlefield and just asked to get at it and go and suture it. The problem with that is that because there was no specialist training, and he may never have seen a vulva before, depending on his background, he had no real understanding of what he was doing. There's no standardized equipment or suturing materials or methods. And from memory, the end result was often a mismatch of tissues. Some of those tissues didn't even match in colour or alignment. So, and women would be sent home like that, and that was just how it was. And it's hard to believe. And I know I'm retired now, but I don't feel that old, and it isn't that long ago in chronological terms. The other thing that's changed is that I never saw a single woman back from a bad experience, and I know that there must have been lots of them, because organisations didn't have memories, risk management didn't exist, and women were obviously referred to gynecologists, but there was no communication. And to a certain extent, the communication between the repair service and the midwifery service and the obstetricians still isn't great. So you may never hear, unless somebody decides to litigate or makes a complaint, you may never hear about them if they just go through the process of getting repaired. And that's a bad thing. So I think it's been a good thing that women expect more. We as a profession have been asked to be better, and also that there are some communications through risk management and processes that allow midwives and doctors to realise when things have gone wrong, which just didn't happen before. So I think there's no doubt that the outcome for women who suffer perineal trauma has generally improved, and that's really because of specialist training in suturing. I think with midwives being taught to suture, the repair of more simple tears has improved, partly because they get sutured hopefully nearer to the time of birth rather than having to wait for a doctor to be free. The use of subcutaneous, subcut to the skin makes it more comfortable, and we've got dissolvable sutures now, and the holy grail is rectal Voltral. I mean, you very rarely see anybody that isn't mobile after a normal birth quite soon, even if they've had a significant perineal injury, and that quite often is because they've had good analgesia now. So all of these things have improved the outcome for women with first and second degree perineal trauma. For third degree tears, the outlook has improved following the improvement in training for identification and repair, and the requirement that the repair is performed, as Andrew's pointed out, by somebody who's appropriately trained, and I think as soon as possible after the birth. So when I was on the labour suite and I got a woman who'd got a third degree tear, I tried to make sure that she was in that theatre as quickly as possible. You can't always do it, but it is important, because it improves the risks of and going to theatre as well, and as Sarah pointed out, the need for decent lighting. It improves the outcome and reduces the risk of infection. There has been a significant increase in the identification of oasis in recent years, despite improvements in care, and I think that has to be, in part, and as has been shown in the research, to do with recognition, because, again, going back to the 80s, and I don't want to keep harking back, I don't think I ever did a rectal examination. Well, I know I didn't, not for years and years. I only started doing rectal examinations when I was taught to suture in about 84, 85, and that became part of that training. But it hasn't been a standardised thing. But actually training midwives to perform rectal examinations has had a positive effect. It can cause a problem, because in my own trust there was a big warning because we'd suddenly gone, leapt up several percentages with our third degree tear rate, and there was this huge investigation and individual names to see if they were cropping up, was examined, and actually there was nothing to actually pinpoint other than we were better at finding them, which begs the question of how many women went home without that diagnosis and who've subsequently had these awful problems. I mean, it doesn't bear thinking about. I'm just going to go back to the 1980s for one tiny bit longer. Betty Sweet and Maggie Miles were the two sort of titans, if you like, or the giants of midwifery practice when I started, and they edited both of the major textbooks, and they would both be horrified by the idea of a hands-off birth. If you look in those textbooks, if you're lucky enough to find one, you can see really detailed descriptions of how you should tease the head out and hold on to it, and actually not supporting the perineum, but more supporting the head to prevent it popping out. And any midwife listening to this ramble will recognise when you've had a lovely normal birth and then suddenly the woman gives a whopping push and out pops the head, and you dread to look what's underneath that baby's chin, because you're expecting terrible trauma. You don't always have it, and you're relieved when you don't, but that's what happens. Now, the midwifery recommendations when I started are very similar in some ways to the Finnish grip that we talk about now, of holding on to the baby's head. But there was a recognition even in those days that actually putting a lot of pressure on the perineum and supporting it is actually not that effective, and actually can actually cause more trauma than you're trying to prevent. Another thing that's really interesting, especially if you read Maggie Miles, was that putting women at the centre of care and decision making was talked about in those days. In the 1980s, it was a very paternal sort of approach. So you talked to women, you told them what to do, but you were involving them in their care. Now, putting women at the centre of care and decision making is talked about in all guidelines, and the idea is to make the woman the centre of the care, and that has to be a better approach. When it works really well for a midwife and a woman is when you have both having respect for each other, communicating well, encouraging the woman to be in control. And I think something that we always try and talk about but we forget is listening to women. Don't brush them off with oh, common things are common, or oh, I know how you feel, or don't worry, that will get better. So all of those things are really important, and they're talked about ad nauseum in NICE guidelines, but actually translating that into present practice isn't always easy, but it should be the most important thing. I think building such a rapport is possible even if you only meet that woman for the first time in labour. And I know from my own practice that most of the women I looked after, I met for the first time when they walked through the door, either in active labour or in latent phase. I didn't know them before, although I have worked as a community midwife, and that was a joy. But case holding schemes and other local initiatives like that really do provide an opportunity for midwives to give women lots of information in the antenatal period, and to be there for them in labour, to put to work with them to try and improve their outcomes and prevent perineal trauma, amongst other things. I mean, I wonder how much of the requirement to keep women at the centre of care actually plays out in reality, and how much are women told about the issue of perineal trauma, even though we know that we should be telling them, what decision making do women actually do? Because if you go to a labour room, you are talking to women, you're constantly explaining, but when push comes to shove, we easily as a profession go back to that more paternalistic attitude of telling people what's going to happen, and women get very little information. So while everything's going along smoothly, there's a dialogue, but that can change very quickly at the labour point. If we do nothing else, if you take nothing else from this talk, I would reflect on that point as midwives. Think about how you actually interact with women and how much information they get in antenatally, and how much respect you give that woman in the labour situation. I don't think that information about what's going to happen in labour and perineal trauma should just be a tick list of headings. It should actually be a real discussion. And also recording some of that discussion wouldn't be a bad thing, actually. I just do think that, having listened, I think I've been very affected by listening to Ashley and Sarah, actually, but it is, for me as a midwife, one of the reasons that I wanted to start the training for first and second.
I'm so sorry, I think we've lost Sue there. She's frozen. On that note, I think we'll end Susan's talk there, and I'm sure if there's anything that she needs to pick up on, she will be able to do that in the panel discussion that's coming up shortly. So apologies for that, but Sue, if you can hear us, thank you so much. That was really fascinating and really built upon what Paula said earlier on about prevention being better than cure. And obviously what Jan was alluding to with information being power, and what the focus of today is really bringing the effects of perineal injury to the forefront and into people's minds, and trying to raise awareness of that and bringing it more into the narrative of childbirth. So thank you, Sue, for that. Our final speaker for today is Tenendai Ziwara, who is the Maternity Clinical Improvement Lead for the Eastern Academic Health Science Network, and she's also chairperson of the Paediatric Pan London Oxygen Group. Tenendai is passionate about improving patient care and making all services as safe as possible without compromising quality. She brings about innovation in service changes, and she pushes for better in healthcare service delivery and leads various programmes in the east of England, and hopefully she'll be able to explain a little bit more about what she's doing with these innovative changes. So over to you, Tenendai. Thank you.
Thank you very much, Sharon. I'm not going to go through all the slides that I'd prepared, because I think you've had enough slides for the day. So as it's been introduced, so I work for the Eastern Academic Health Science Network, and part of my role is actually addressing in the vision for the NHS long-term plan and the Better Birth is to reduce the rate of stillbirth and neonatal death and birth injuries during and soon after birth by 50% by 2025. So it's a slightly different topic from what this, but actually what I want to bring today is where does patient safety stand? So why is quality improvement important in patient safety? So you've spoken about breaking the silence, and we've had the the experience from Ashley and Sarah and what they've gone through. And I want to bring in to say, actually, what next? What should we be doing? What should we be actually saying to our systems, to our trust, to our hospitals, to our communities to say, we now know this information. We now know women experience this. This has been happening for a long time. And one of the things that we know from the NHS long-term plan was the maternity transformation program. So if some people have already heard about that. So the maternity transformation program, they've done some, we've got fast followers and early implementers within PAVIC health services. So earlier on, as you remember, Paula was talking about the innovation and the things that they're doing within their hospital. And part of that, there's been some funding that has been released out to different systems, different hospitals, to actually say, if there's innovation, how do we bring that innovation? How do we support that work so that we can bring a better experience for the women or the birthing people that are accessing the maternity services? And I think that is the key. So you might say to yourself, okay, based on what Ashley and what Sarah has highlighted and all the speakers have highlighted, what do we need to do? We from the from a quality improvement is actually saying, okay, what ideas do people have? How do we start bringing those ideas, to bring those innovation ideas, to start making those changes? And we can only do that through different methods. And as you can see from that slide, so quality improvement is about using a systematic method to actually involve the people closest to the issues. So this is your women, probably your carers, or it might be, because carers are really important. I think what Sarah highlighted, having her parents, having her husband being part of it, them sharing that to say, actually, we know that this is what she's gone through. This is what innovation we can bring to you. This is what we can share with you, and what all those contributions is quite important so that we can start making those changes. And we've got innovation department, we've got delivery department, so that we can actually capture that innovation. And then what we do, my role is to then go in and say, actually, how do I support that quality improvement so that we can bring a better safety element within the organization? I always say, when we hear these stories, we're tired of hearing women going through all these experiences and saying, oh, we know about it, or we hear about it, but it's what are we doing about it? How can we start discovering solutions? And if we know solutions, how do we share those best practices? If it's happening in St. Thomas, how do we cascade that information into different areas than us repeating and different things? Actually, and that's what quality improvement is about, is sharing that information. And you might say to yourself, okay, how do we do that? And I think one of the things is always thinking, co-designing. We need to bring the patient, the carers, to be part of the co-design. They usually know what the experience is. They know the answers. They will tell you what they've gone through and how they can, what you can do to solve that issue. You need to think about safety culture. Has this been happening quite often within that organization? How many women have brought the similar cases time and time again? And what can we do to start changing the narrative? And then we think about that quality improvement. What are the tools we can do to start changing that practice? The innovation. Who has an idea? Maybe there is a junior clinician that has been thinking, or a midwife, or it might be somebody within your network that's actually saying, I know the solution, but nobody can hear me. How do we hear to those voices so that we can start capturing those information? And then actually, we know with COVID, people are stretched out, people are tired, people are in burnout, but how do we make the capability and give them capacity to actually bring those quality improvement work? Because we know that just because we've got COVID and people are tired, problems don't go away. Issues still happening. Women are still going through perinatal injury right now. So how do we make sure that we don't use that as an excuse to not address the issue? And then importantly as well, it's about thinking about improving the leadership. Is how do we support leaders to hear and support this work when it's coming on the table, when it's coming into that office, and actually say, how do we address when we're hearing those service user feedback through our surveys, through reports, through letters from any organization, might be from your solicitor, but how do we bring that to actually say, as a leader, what do I do about it? How do I make those improvements? And one of the things that I think it's been highlighted by other speakers, is about addressing inequalities. I always say, who else is right now missing on the table? Who else have we not heard from? Because we know that there's groups of women that have no confidence at all. The Sodom head will never come and speak in this forum. They will never be able to go to their GP. They will never be able to go to their obstetrician and say there's a problem. And we know those groups of women are even suffering the same level as any other person that is given the experience. So how do we make sure we capture that voices and actually be able to bring and say, actually, we need to know your experience, and we need to use our quality improvement, methodologies to actually make those changes. To me, that I think the success is how is bringing those things, all those elements together. Part of it, we use a peer framework, is about prevention, identification, escalation, and responding. We need to be able to do that. How do we prevent it in the first place? And I think items have been, highlighted by Paula earlier on. How do I identify that now there's a problem? How do we capture that problem? And then how do we escalate if there is a problem? If I'm a junior midwife or a junior nurse or an obstetrician, whatever you are on that role, and you've identified there's a problem, how do you escalate? Do you feel confident enough to escalate? And even for the patient, even for the woman or the birthing person, do they feel the confidence to escalate the issue? Or is it actually being documented and left in the notes, or actually nobody knows about it? And how do we respond to the problem? And I think that, to me, one example that I've given you is about quality improvement. Now we know the issues. Now we know it's been happening for years, and we know things are slightly starting to improve. We've got the pelvic health services that have been given funding in different areas to start doing that. But we know we've also developed through the maternity transformation is the maternity mental health services, because we know that most women that go through birth trauma, most women that go through pelvic health, perinatal injury, actually going to end up accessing perinatal services, mental health services, maternity mental health services, because the issue doesn't just stop physically, it continues with mentally, and they need that support. So I think it's important. I'm not going to talk much, but I think to me, it's just highlighting that. And I think I'll end with one example. I think a couple of years ago, I was doing a clinical shift, and I'll never forget, as similar as what Ashley and Sarah has highlighted, speaking to a colleague who was working on that clinical shift. And what I highlighted is they just started talking about the experience that they've had pelvic health injury, and they've gone through so much, and that it led to their divorce, and that they had been suffering for years and years. And to me, when I heard the stories today, and I kept on saying, this is what we hear time and time again. And what are we doing about it? What can we do? And to me, it's just opening that if there's ideas, if things that we can do, and how we can support from a quality improvement to start shifting that pattern, to start making that difference for the next woman, for the next family, because it doesn't impact one person, it affects the community. So for the next person, for their next career, because they will stop their job or they will change their career because of that issue. So how do we do that? And to me, it's how do we start using quality improvement methodologies to actually change that patient safety. So thank you.
Thank you, Tenendai. That was really informative. And thank you to everyone that's been speaking today. It's been incredibly insightful, and I'm sure everyone's taken a lot from all of the presentations today. We are going to depart from the schedule very slightly, as we have run over with our talks, but they've just been absolutely fantastic. So we're going to go straight into our panel, and I'll hand over to Julianne Moore, who's going to chair that for us.
Thank you so much, Sharon, and apologies that we've had to forgo our little comfort break, but as everyone has heard today, we've had some really fantastic talks, and we wanted to make sure those could run their natural course. So we're moving over to the panel discussion, and I'm pleased to say that most of our speakers today have remained on the webinar. We've had a couple of departures, as I say, because of clinical commitments. And we're also joined by two further individuals. We've got Miss Caroline Vasey, who is a colorectal surgeon, and Caroline is the lead surgeon for intestinal failure at St Mark's Hospital and the National Bowel Hospital, and she's the director of the physiological unit. She's also the divisional clinical director at St Mark's, the chair of intestinal failure subcommittee, and the chair in waiting for the Pelvic Floor Society, so she's extremely experienced in this area, and she's also written quite a number of books and chapters on her interest, particularly in this area, and a number of papers. So welcome, Carolyn, to the discussion. We're also hoping to join us, but Charlotte's got a difficulty in joining onto the link. Another obstetrician, Charlotte Hay, who's a consultant obstetrician and gynaecologist in London, and she's got a dual accreditation in OBS and gynae, as well as having a higher subspecialist training in urogynecology and has a fellowship in neuroneurology. I'm not sure if we've managed to get Charlotte onto the link. I think they're telling me, unfortunately, she's been unable to join. So you may be able to join during the panel discussion, and if not, I'm going to put Mr. Farkas in the hot seat on some of the questions that I was going to ask Charlotte as well. So thank you very much for all the questions that have come in thus far. I'm going to sort of start off with some of them, and sticking on from Sue's fantastic presentation earlier. One of the questions that's come through, and I think it'd be ideal to answer this, Sue, is how birth injury impacts on infant feeding choices. I don't know, in terms of Andrew, if you can answer that question from your aspect of a obstetrician.
Sue's muted, needs to unmute.
Right.
I think from an obstetric perspective, anyone who's had a significant problem at birth, whether it's perineal trauma or anything else, has difficulty in the practicalities of establishing breastfeeding. They're feeling physically drained, they're feeling emotionally drained. And once you get it off to a bad start, it's more difficult to get things back on the right track. Sue's unmuted now. I'm sure she'll have something to say.
Yeah. No, I agree with all of that, but also there are things you can do, but it just takes time. And I think that one of the problems, certainly in hospital, is positioning immediately after trauma, because you don't have to sit up to feed a baby. So once you've got over, if you've been to theatre and all of the things that go with that, positioning, but it is all a matter of time. And the trend I was talking about, you know, how do you do all these things with short staffing or worn out people? And one of the things I was going to come on to in my my talk, but I got cut off, is the aspiration to do all of the things that women need, balanced with the staffing issues, and also the, like, for instance, as a community midwife, you have so little time to spend with each woman now, and you really want to spend all day with each woman, but you can't. But if you can prioritise doing the things that women really need and cut out the things that perhaps are peripheral and not that important, one of the things that really would help women is being able to hold their own baby and feed it themselves following a perineal trauma, so that they don't feel, I mean, I think it was Ashley, I came in a bit late for Ashley because I couldn't get connected initially, but she was talking about how she didn't hold her baby to start with, she didn't do the first. And that is really sad, and that happens to any woman who's usually had a general anaesthetic. But even going to theatre for perineal repair, you do miss out on that initial thing. But, you know, bringing the woman and the baby together as soon as you can really is important, and it is a priority. It's not a peripheral thing. That's really all I can say about that.
That's fantastic, Sue. And I know, Sarah, from your own personal perspective, you wanted to make a comment on this, didn't you, in terms of the impact of your own birth injury on obviously being able to sort of bond and feed your son?
Just really the practicalities of feeding a child when you are going into hospital for surgery or on medication. So there's a lot of planning that needs to go into that, you know, the pumping and storing, and then as Mr. Farkas said, you know, once you're in that process of being in hospital, being operated on your drain. So I mean, for me, I was able to bond and we were able to feed for 3 months, but it really did mark the end of it for me.
Okay. Sorry, really sorry to hear that. Another question that we've had, again, it might be one for you, Sue, because generally water births are managed by midwives, in my experience. And this is a question that's been posed by an obstetric registrar based on her experience, is that she's noticed there's an increased rate of third-degree tears associated with water births. And she wants to know, have you noticed this in your experience or any other members of the panel? And are we able to offer any advice on how to avoid that risk?
Well, I think the evidence is not straightforward one way or the other, because you can get evidence that it doesn't increase, and then evidence that there is an increase. I think that in an ideal situation, if the woman is relaxed in the water and she's able to stay in control, you can't do any hands-on in the water, it's not practical. And if you can work with the woman and get her not to push as the head is crowning, then you're no more likely to get a third-degree tear with your hands-off approach than you are with a finish grip on a bed. But I think it is all about relationship, and there are some women who, even though they're in the pool, are completely out of control, and it is really difficult to manage. But it is just trying. It was something I was talking about when I got cut off, you know, that trying to build that rapport with somebody so that you are working together, so that you're in it together, is how that. But there is nothing else that you can do. But actually, generally, in my experience, in my own unit, we haven't had an increase in third-degree tears in the water overall. There are little peaks when you look back at 3 months of evidence, or that there have been some peaks, but generally it hasn't been a big issue at all. But that's because we want women to be well prepared when they get in the pool, and so I hope that's answered the question, but it may not have done. Might have been a bit waffly.
I think not at all. I think it does. I think Mr. Farkas, you've got a point you want to discuss on this.
Can I be controversial, and I accept that in this company I'm the sort of male obstetrician here. I'm all for the water pool for analgesia in labour, but I think when it comes to birth, it's not so straightforward. And I mean, Sue very fairly raises a lot of ifs and more ifs, and contingencies about the good circumstances for a water birth. And fine if everything goes absolutely according to plan. But having said that, I think she's also right that the evidence about statistics and third-degree tears is to a large extent anecdotal. I mean, you get that feeling, but it's very difficult to pin down. But analgesia is my view, rather than birth in the pool.
And I think that's spoken like a good obstetrician, because and most neonatologists always think the same thing, but actually if you're present for a water birth, they're usually really lovely experiences, and women love them if it go, if they carry on in the water and they don't want to get out, and and it's difficult to make a woman get out when everything's going really well, isn't it?
That's great.
It's also difficult to get a woman to get out when things are going disastrously wrong in a hurry at the end. That's the problem.
No, we train for that. That's actually quite achievable if you have the right training. So,
and Carolyn, I
noticed preparation.
Caroline, I noticed you were nodding your head there about, I don't know if you've got any observations from a colorectal point of view and what you've seen when you're doing the sort of secondary pairs and the sort of correlation with water births.
Like Andrew, I get this, I think that there is a correlation, I get that feeling, but at least the obstetricians can't get their forceps out underwater, so that's one mercy.
Oh, I love that.
Fantastic. That's good. So hopefully we've answered that question. Another question that's been posed, and again, it might be one for Andrew initially and then Carolyn, is what percentage of perineal trauma is attributed to common practices that increase the risk of tears, including the birth position, and if I say this right, the Valsalva technique? I don't know what the Valsalva technique is, so if you can explain that to the ignorant in the audience like me and probably some of my other legal colleagues.
If you're trying to blow through a fixed mouth, a closed mouth, in generating increased abdominal pressure, I think it's very difficult to sort of pick out which factor is, more important. I mean, the multivariate analysis that I referred to in the college guideline gives some idea, but which of the normal practices and, in normal childbirth, I think it's very, very difficult to pick them apart. I don't know. Sue and Carolyn may have an idea.
Carolyn, have you got any observations on that from what you've seen?
Other than my hang up about forceps, one size fits all, and how absolutely and utterly archaic they are. No.
Right. Okay. Okay. So just moving on from those, so a lot of things that's been Andrew discussed in his presentation was about obviously the training that obstetricians receive in respect of perineal trauma, and you talked about it being 1 day of training. And one of the questions that one of our delegates has posed to you, Andrew, is does the day training that junior doctors attend consider and discuss the emotional impact of women on the women themselves, the baby and their family? So does that training also look at that emotional and sort of psychological impact, as well as actually the kind of hands-on on how to spot it and how to repair them?
To be honest, no is the answer. It tends to be mechanistic about how to put the tissues back together. I think you're being a little unfair in calling it just 1 day's training. I mean, it's a day's training added to the clinical training that the trainees receive as they go along. But no, I mean, the question is absolutely right. More heed needs to be taken on what's going on behind, why we're there.
So that might be a recommendation effectively going forward, and it might, include in that training and that ongoing training and as well. Jan, sorry, Sue.
Sorry, I'm sorry to interrupt. I actually did the training with some years ago with the idea that I would take an active role in repairing third degree tears, not fourth degree tears. And we had a 2-day training, but there was quite a bit on the first day on emotional and aspects of the perineal trauma and the effects that it had on women. So maybe the training has moved on a little bit since then. I mean, I decided not to carry on and do repair of third degree. I think that's very much an obstetric role, but it did help me to identify third degree tears in clinical practice. So I was glad I did the training. But I do remember having some slide presentations about the emotional aspects and the effect on women and the importance of getting it right. So that was, there is some in more modern training, maybe.
That's great to hear, Sue. Thank you. Another question that we had, Andrew, following your presentation was about when you were talking about the different types of repairs. So one delegate posted, have to be honest, it's terribly frustrating that trainees often think that they have overlapped a 3A. They are absolutely fixated on it. Would you agree that a good end-to-end is better than a cobbled together overlap? And that might be something, again, for Andrew initially and Carolyn to comment on.
Yes, I agree. I agree with that, absolutely.
Okay, and Carolyn, what in terms of when you see them, when you get them in terms of secondary pairs, have you got any comment to make on that?
So you can only do a real overlap if there's a full thickness tear throughout the external sphincter. Otherwise, you can't really overlap it. You have to divide it to overlap it. So, I just don't buy that you're going to do anything but an end-to-end on something less than, a full 3B right throughout.
Okay, so I'm just going to shift some of the questions now back to obviously the psychological support that people should be offered when they've suffered a perineal injury. And one of the questions that's posed, and perhaps we can start off with Jan, and then maybe after we've spoken to Jan, move on to Sarah's experience, is in respect of what are the key considerations for ensuring psychological support for those who have been impacted by perineal injury?
I think it first starts off with a preventative element. So in that antenatal period, having discussions with women and birthing people, but given the huge shame and isolation and feeling alone whenever you have perineal injuries, I think there's lots of support and organisations out there that women can feel heard, and they're in groups where they feel supported. So there's MASIC, there's also the Make Birth Better, which I'm the clinical lead of, and there's loads of resources out there on our website for women and birthing people, if you're not sure what to say to your GP, you know, there's things that you can just print off and take with you, but also things for healthcare professionals to look out for in supporting these clients.
That's really helpful. And Sarah, from your own experiences, what do you think would help in terms of providing that support to ladies that have suffered birth trauma?
I mean, I don't have any overriding feelings other than it needs to improve dramatically. Again, I felt quite lucky in that I had a good conversation with my health visitor who suggested reaching out to the BTA. I don't know that I would have done that had she not suggested it. So maybe the way in to sort of start the conversation with women is when they're at home with their health visitors, having, I don't know, maybe some training of local community midwifery services, just to get the ball rolling so that women are thinking about where to go for support, or even knowing that it exists, because I wouldn't have known anything had I not had that conversation with my health visitor.
That's interesting, and obviously some really helpful advice there for our clinical colleagues. I've got a question for you, Tendai. So someone's posted a question, a delegate, and said, I want to be heard, but so many barriers. They knock my confidence as a practitioner. How do we find a tribe and change without appearing to be radical and a dreamer and unrealistic?
Yeah, I think that question, I would say the first thing you need to think about if you're, you know, a midwife or, you know, within, or even an obstetrician or a doctor, is you've got your maternity and neonatal safety champions. So every hospital, every department has a maternity and a neonatal safety champion. These are usually at executive level or non-executive level, and they are the best people, because most now, one of the things that's happened is that there has to be either a suggestion box or a contact number, email address that the midwife or the clinician should be able to email them and say, actually, could I have an appointment to talk to you? If you don't feel comfortable to go that high up, is also, you know, who are also the other movers and shakers within your organizations. You might have a very, you know, proactive, you know, director of midwifery or a deputy head of midwifery or any person that you actually say, actually, these are the movers of shakers in the organization that I need to escalate an issue. But most of the time, your safety champions, they come as well to any regional work. And as well, you got your freedom to speak up as well, champions in every organization. There should be contacts or emails or numbers that you can, as a professional, to utilize to contact them. So these are all three people that you can make contact with, email, telephone, or anything.
That's really helpful, Tendi. And whilst you're on, I've got another question that's come through. So first of all, the first part of the question is a bit of an observation, and then there's obviously some queries there what you might be able to help with. So someone said it comes down to changing the whole system so we have the time to spend with women here and actively really listen and be the midwives we need to be and we want to be, and we've heard all that, and we know that when we see that in our work in the medico-legal side of things. So what they want to know is, how can they do that? How can we learn from the medico-legal aspects and start spending our money to prevent, and where do they lobby?
So I think some of the work that's already currently been happening is part of the maternity transformation. So we know about the midwifery continuity of care model. So that's been one of the things that's been campaigned, and that's actually being a driving force right now from our national team, is cutting down the amount of caseloads the midwives are having that are not on that model, so that the midwives have a focused, you know, time and care for their, you know, women, right from the antenatal period right to postnatal time, even be there with them during delivery. If you know your midwife, you're more likely to open up, you're more likely to even spend that time. They also know what you like, your fears, they know things that, you know, that you've gone through, and they're more likely to have that time to support you throughout that. But also, if there's issues that you need to escalate, if you're, you know, a woman or a service user, is actually you've got your maternity voices partnership. These are service user voice that you can actually link up with, and they do surveys. They actually are always recruiting to have more service user voices to actually say, come, let's hear your voice. What are the issues and how we can escalate? And they do send representation in different platforms, different work streams, so that these changes happening. So we would love a big system change, but actually there's different work streams that are happening at different paces with different deadlines. So actually, if you utilize your Maternity Voices partnership to say, what is happening? How can I get involved? Do you need a lived experience person to actually be part of it so I can share and make those changes? They will definitely be able to recruit you and, you know, get that support.
That's really helpful, thank you. Now I'm conscious of time. We're due to finish at about 15:15. I've got a couple of questions. Hopefully we can get through. If we don't get through all the questions and you've posted one, obviously if you posted your name, then we can obviously get the response from our fantastic panel and we can email that response to you. So the last two questions I've had, again, probably for the obstetricians in the room and Andrew, how much training and experience do obstetricians have in active childbirth and normality with the associated benefits this can have in reducing the risk of perineal trauma? So that probably is for Andrew.
Well, first of all, let me say how much, as an obstetrician, I would support normal childbirth wherever possible, and I am keen to avoid interventions if at all possible, and it's not just lip service to that. How much do we get in terms of active training? Relatively limited, and that starts at medical school. It used to be that medical students had to see 10 deliveries, do 10 deliveries, then that number came down, then it was 3, now there's no set number at all, now they hardly have to see any babies being born at all. So the tone is set badly from the beginning, and there is very little training in normal birth.
Thank you for that, Andrew. And then we've just got time for one final question, and it might be one really for Andrew and Carolyn. So the OC Care Bundle was piloted in 2018 with good evaluation. The question is when is this going to be offered to all trusts across the country to standardise the care offered to women? I don't know from your experience and know-how when this is going to happen, or if it's going to happen.
Sue may have a clear idea. As far as I'm aware, there aren't plans to bring it in. I mean, the concepts of it are very positive. I do have issues around the information sharing, and that's a sort of philosophical thing in a sense, in that one of the major tenets of the OAC Care Bundle is informing patients about perineal trauma, but there are an awful lot of competitors about what you inform patients about. You know, antenatal screening, ultrasounds, fetal movements, the works. And I'm not trying to be a patronizing male obstetrician here, but how you don't laugh, Carolyn, but how you not only prioritize and work out what should be given is a very difficult subject, and everyone doing their latest guideline or care bundle thinks their information should be disseminated. I don't think there's a ready answer to it.
But can I one of the things I was going to come onto in my truncated talk was about exactly this, because you know, there was some research that I read that said that midwives were frightened to mention to women anything about perineal trauma because it might make them ask for a cesarean section. But there is also evidence as part of the OASIS Care Bundle that the requests for cesarean section don't rise. But what does happen if you explain things to women is that they have a better understanding of what they're dealing with, and so they're not walking around with a blue balloon and a pink balloon thinking that's all maternity is, and that, you know, things can go wrong, and they're better prepared for it. And I think we have a duty. I was going to talk a little bit about Montgomery as well, because we have a duty to actually keep women informed about things that actually do have the potential to impact. So we can't not give that information to them. But as part of the care bundle, most of the information giving is just a leaflet to the woman, and we know that leaflets aren't often read. My own friend has just given me a whole bunch of them and said she never read any of them, and she's a clever girl. So it has to be more dialogue, but then when you've had that dialogue, you do need to report it. So it is really important, and it's as important, if not more important, than some of the other information that Andrew quite rightly listed as needing to be discussed. So
thank you, that Sue. So I'm conscious it's nearly 15:15 and we're due to finish. So I just want to say thank you so much for all the speakers and for everyone attending on the panel. So I'm just going to hand over to my colleague Anne, who's going to close the webinar today. Thank you.
So thank you so much to everyone for your contributions this morning, to our professional speakers and particularly to Ashley and Sarah. I think it's been a really valuable and thought-provoking session. I just wanted to confirm that information on where to download fact sheets and leaflets referred to by Laura and some further information from 10-Day will all be sent on to the registered attendees. And I think it's also important to highlight the charities who support women and families that we support as a firm. And those details are within the programme, which was sent to all delegates by email earlier. And finally, the recording of the webinar will be sent to you by email soon after the live event, and you'll be able to watch it again or share. One measure, I think, of a successful webinar is the level of engagement we receive on the live Q&A on the day, and I can see we've had a lot of that today. And as Gillian just said a moment ago, if you submitted questions which weren't addressed in the Q&A, we will follow up with you afterwards if we've got your name and email. And that also leads me on to a little request for feedback. So please complete the feedback. It takes about 30 seconds and it really helps us to evaluate these webinars and plan for the next one. Finally, I would just like to flag our support for Through the Dark Lens, which is an online conference on the 12th and 13th of November. I think it was on your screens and yes, it's come up again now. Many of you will be aware of the Embrace findings on the significantly poorer outcomes for Black and brown mothers and babies. And this conference is a gathering of expertise in all areas related to maternity care, which will attempt to focus on improving knowledge, skills and cultural safety for all those who work and access perinatal health. Once again, thank you all for joining and have a good day.